Please.
Hello, everyone, and welcome to the 6th International Ophthalmology Conclave to our session of Cicatrizing Conjunctival Diseases, the current diagnostic and management protocol. Our program director for this session is Dr. Sayan Basu and Dr. Swati Singh, and I'd like to welcome our chairperson, Dr. Virender Sangwan, to start the session. Over to you, Dr. Sangwan.
Yeah, good evening. Thank you, Maria, for the introductions. And it's my pleasure to invite you, all of you, on this very, very interesting, symposium on cicatrizing conjunctivitis with a excellent group of speakers. I'm sure you will learn at least very practical things from this, the kind of speakers that we have. In your practice. These conditions are very common and clinically sometimes very difficult to differentiate, say, between OCP and SJS or variety of other conditions. So I'm hoping that by the end of the session, you should be able to make clinical distinctions and have a diagnostic algorithm and management plan for each of these conditions. Thank you very much. Swati?
Yeah, thank you, Dr. Saman. I'll share my PPT. Can you see my slides?
Yes, Dr. Swati, it's visible.
Thank you, Maria. Yeah. Good evening, everyone. Thank you so much for being with us. And I'm going to introduce our speakers as well as the panelists who are an expert in cicatrizing conjunctival diseases. So just now you heard our chairperson, Dr. Virender Sangwan. I think he doesn't need an introduction. He's currently heads the innovations at Dr. Shroff Charitable Eye Center. He's internationally recognized ocular surface expert and has been recipient of numerous prestigious awards. And his pioneering work is simple limbal epithelial stem cell transplantation, which many of us are currently using for our patients. Our international faculty is Dr. Hong Chi Hong, who's ophthalmologist at Singapore National Eye Center. He has done his PhD in the ocular surface in ocular pemphigoid at Moorfields Eye Hospital. And he is a recipient of the prestigious Elizabeth Hunt Medal from RCO, UK. And he is also heading the eye bank services at SNEC. Our second international speaker is Dr. Hazira Saeed. She is an internationally recognized expert for Stevens-Johnson syndrome patients. She's currently an associate director at University of Illinois, Chicago, and she has numerous publications related to the management of these complex ocular surface diseases. Next, we have Dr. Sayan Basu, who's a director of research at L.U. Prasad Eye Institute, and he is a pioneer in developing the limbal stem cell transplant with Dr. Sangwan, as well as now currently cell-based therapies for ocular surface reconstruction. He's a recipient of multiple international recognition and recently concluded the first approved clinical stem cell trial use in patients with ocular surface diseases in India and in the world. Next, we have Dr. Namrata Sharma, who again needs no introduction. She is a chairman scientific committee at All India Ophthalmology Society, and she's a professor at All India Institute of Medical Sciences. She has almost 700 plus publication and has been recipient of numerous awards and has published a lot of clinical trials, especially randomized controlled trials in patients with ocular surface diseases. Next, we have Dr. Shweta Agarwal, who heads the ocular surface services at Shankar Netralaya, Chennai, and her recently education initiative YouTube channel is very famous among the ocular surface experts, where the innovative and beautiful surgical videos are being uploaded. And she's recognized for her excellence in comprehensive NTL segment management. Next, we have Dr. Vikas Mittal, who's the director of LJI Institute at Ambala, a very proliferative corneal practice in the private setup, and who's widely known for managing very complex cases from the north of India. And he's been active contributor to many of the ophthalmic conferences and has mentored many of the cornea fellows in his center. Lastly, we have panelist Dr. Jayesh Mazirani, a very close friend, and who's again a private practitioner who manages a lot of complex cases with a lot of systemic immunosuppressive and other surgical techniques at XLI Care, Ahmedabad. He has published extensively in high impact ophthalmology journals and routinely every yearly conducts ocular surface workshop at Ahmedabad, which is very, very useful for the ocular surface experts. So with this lineup of extremely talented speakers and faculty, now I first invite our first speaker of the day, Dr. Hon Shing Ho, who's going to talk about the mucous membrane pemphigoid.
Hi. Thank you very much for the introduction. Good evening. Thank you, Professor Virender, Sayan, and Swati for the invitation to speak at this conclave. So I'll be speaking on the diagnostic nuances in ocular pemphigoid and cicatrizing conjunctivitis, the phenotyping. It's basically forms part of the PhD that I did with Professor John Dart. These are my disclosures, which are not relevant to this talk. So mucous membrane pemphigoid is a chronic autoimmune blistering disorder driven by IgG and sometimes IgA, and it is a type 2 hypersensitivity response where autoantibodies target the basement membrane zone complex of the conjunctival and squamous epithelium. Examples are the BP 180, BP 230, laminin 332, the various laminins, alpha 6 beta 4 integrin, and type 7 collagen. And this leads to activation of complement and numerous inflammatory mediators. And in the acute phase, the release of proteases is responsible for the dermal epidermal adhesion disruptions resulting in mucosal blistering. The recruitment of inflammatory cells, and this can be includes neutrophils, lymphocytes, mast cells, eosinophils, into the substantial propria of the conjunctiva accounts for chronic inflammatory manifestations. And the consequence of chronic conjunctival inflammation and fibrosis leads to things like your corneal limbal stem cell deficiency with associated corneal pathologies that lead to visual impairment. Eyes are involved in 60 to 70% of pemphigoid cases, and the sole site, ocular-only pemphigoid, accounts for 15 to 20%. So this is important as we may be the only physicians who would ever diagnose it in some patients. These are the stats. It's still considered a rare disease, more common in females, and there's a peak age of onset between 60 to 80 years, so the elderly population. This unlike the Stevens-Johnson's population. So this is a population-based study conducted in the UK on cicatrizing conjunctival diseases. And as you can see, the majority is due to pemphigoid, and this is the case in the Western world. Pemphigoid is relatively rarer in countries with predominantly Asian populations where the most common cause of cicatricial disease is Stevens-Johnson syndrome. But due to some unknown factors, pemphigoid diagnosis is getting more frequent in certain Asian populations, including parts of the Indian subcontinent. So there are, however, over 30 other causes of cicatricial diseases as shown in this slide. So cicatricial conjunctival diseases can cause a significant ocular morbidity. Patients often have chronic symptoms and it can be debilitating and painful. Bilateral blindness has been reported in as high as 20% of patients with pemphigoid. And the loss of vision in these conditions occur due to the effects of chronic inflammation and scarring. And these includes epithelial instability, as is shown in the top left, with risk of infections, conjunctival scarring in the bottom left here, lid margin keratinization, corneal scarring, vascularization in the top right, and in severe cases in the bottom right, severe ocular surface dryness, keratinization with total ocular surface failure. A hostile corneal environment is formed, which includes chronic conjunctival inflammation and scarring, goblet cell depletion, aqueous tear deficiency, and limbal stem cell deficiency. And this hostile environment results in epithelial instability of the cornea. And the consequence is ulcerations, infections, and also corneal melts. In pemphigoid, even when the eye looks relatively quiet, fibrosis can still be advancing. And previous clinical and laboratory studies have shown that clinical control of inflammation does not cease the progression of scarring. and that stromal expression of both TNF alpha and the pro-fibrotic T cell cytokine interleukin 13 may remain elevated in uninflamed conjunctiva, in keeping of what is previously described as white inflammation. And this makes it a bit difficult to detect or to treat these type of patients. So indeed, these are challenging diseases associated with significant morbidity. Patients require often complex surgery, as you will hear at in the other talks, corneal transplantation or even keratoprosthetic procedures. And not only these surgeries are difficult to perform, time-consuming, expensive, many do not do well and associated with sight-threatening complications such as infections, glaucoma, or even retinal problems. These diseases affect individuals of all ages, ranging from young children and to healthy working adults. For example, for SGS, they can result in significant socioeconomic burden. And you can see that at the bottom here on this picture is a patient who has extensive erosion of the tooth implant of OOKP, resulting in unstable optic with melting of the buccal mucosal graft and exposure, which is a high risk of intraocular infections or even losing the eye. The diagnosis is often difficult, which will be what I'm really talking about today, and I'll attempt to highlight this in this talk. And this partly due to the complex pathophysiological interactions and lack of animal models that the processes resulting in inflammation and scarring in cicatricial diseases are poorly understood. And this translates to a lack of targeted treatment options, and management is often complex and outcomes are often poor. There is often a delay in terms of the diagnosis, and the quote is about 3 to 7 years delay in terms of diagnosis. So this is what we'll be talking about, challenges in diagnosis. So this is from John Dodd's paper, the diagnosis of underlying cicatricial conjunctivitis. Difficult, simply put, there are three main groups of scarring diseases. The first group are those with blinding progressive scarring diseases where immunosuppression is often needed. This includes your pemphigoid, a subgroup of patients with Stevens-Johnson's, which is also known as the, now termed as the non-responders, by Dr. Giester's group, and also drug-induced scarring, which behave like pemphigoid, where they develop both inflammation and progressive scarring. And some of these can be also positive for direct immunofluorescence when biopsies are obtained. The second group are those with ocular surface neoplasia, and they can mimic pemphigoid, although they are often but not always unilateral. Treatment may be delayed if they are misdiagnosed as other causes of cicatricial diseases. And the third group are those that have been previously termed pseudopemphigoid. Although there are some uncommon diseases associated with pseudopemphigoid that may require systemic immunosuppression, for example, your lichen planus, paraneoplastic pemphigus, but most of these in group 3 do not really require systemic immunosuppression drug therapy. And in this group, the scarring is rarely thought to lead to visual loss, although if uncontrolled, inflammation can. So although scarring rarely leads to visual loss, uncontrolled inflammation can. So these are images from three groups, and you can see that they are very similar clinically, and they thus do pose a diagnostic and management challenge in cicatricial conjunctivitis, cicatrizing conjunctivitis. So how do we differentiate between progressive and non-progressive causes of these diseases? So the slit lamp examination should be systematic, including assessment of your plica, where loss of plica is an early sign in pemphigoid, everted tarsal conjunctival inspection, phonics depth assessment, and documentation and photography at every visit. So you can compare this over time. So we have published and validated a one-page cicatrizing conjunctivitis clinical assessment tool, as shown here, which has been shown to have good inter and intra-observer agreement. Our tool has three components: an inflammation score, which gives an indication of disease activity; scarring, which gives an indication of severity of cicatricial diseases; and also morbidity, which is the ocular effects of inflammation and scarring. And each component is scored, and an overall composite score can be derived to give an indication of that overall severity of the disease. And under the scarring component, we use this phonics depth measurer to objectively quantify phonics foreshortening, which is incorporated into this tool. But if you do not have this phonics depth measurer, a systematic serial documentation using photography is often just as good. So taking biopsies is also another way. So basically, normally what I take is one conjunctival biopsy from diseased tissue for histopathology, and this is important to rule out other things like your ocular surface neoplasia, sarcoid, even your atopic diseases. And the second biopsy is often taken from an intact, less inflamed tissue, or also known as perilesional area, which is sent for direct immunofluorescence. And direct immunofluorescence is the identification of antibodies in the basement membrane of affected tissues, useful in differentiating between pemphigoid and also other immunobullous disorders such as pemphigus, lichen planus, which have typical fluorescence pattern from other scarring diseases. The tissue is often sent fresh to avoid a degradation of antibodies and is either sent in a shield with the foil to avoid photodegradation or in special media such as Michel's media. A third biopsy is often taken from the inner cheek for direct immunofluorescence, and I do this regardless whether the patient has oral diseases because this does increase the diagnostic yield. Again, these are sent fresh or either snap freeze or in special media to avoid degradation of the antibodies. Blood tests can be sent for indirect immunofluorescence, but I'll talk about the sensitivities of these later. Serology can be used, but again, these have been thought to show have low yield. And this is from John Dutt's paper, which showed that pemphigoid serum autoantibodies did not provide immunopathologic evidence of pemphigoid in ocular-only pemphigoid patients, but showed limited value in the multi-site pemphigoid patients. And ocular-only pemphigoid serum reactivity was not significantly different from any tests or test combination compared to control participants where direct immunofluorescence negative multi-site ocular pemphigoid differed for 1 LISA and also 3 out of 7 of the 7 combinations. So basically, it's summarized. Basically means that indirect immunofluorescence is not as useful as direct immunofluorescence. So the problem with with the immunopathological diagnosis is that previously the international consensus of pemphigoid have recommended the use direct immunofluorescence as mandatory requirement for pemphigoid, but this is the case for those patients where there are tissues that are involved other than the eye. But direct immunofluorescence is only positive. Only 51% of patients with ocular-only pemphigoid and 26% require multiple biopsies. So we cannot really exclude ocular pemphigoid by a direct by a negative direct immunofluorescence result. And indirect immunofluorescence to identify antibodies, as I mentioned, has low yield, around only 6%. So a negative immunopathology.
Dr. Hong, if I can interrupt you, we are overshooting time.
Oh, very sure. Okay. So I'm just going to go on to the conclusions. So basically what I found, basically this is just this slide. So basically this is the study that I've performed during my PhD. Basically what it shows is that the patients with direct negative immunopathology is basically have similar phenotypes to those with positive direct immunofluorescence. So based on this, there have been changes in guidelines in terms of the European Academy of Dermatology and Venereology, where they've amended the international guidelines of pemphigoid diagnosis to include DIF negative pemphigoid. And so these are my key 6 key takeaways. Think pemphigoid early, especially those with fornix foreshortening and loss of plica. Exclude the mimics, such as the medicine-induced scarring. As this is a multidisciplinary disease, involve your dermatologist, your ENT surgeons, your oral medicine. Always evaluate the fornices, including either a fornix step measure if you don't have a photograph, biopsy perilesional lesions to increase the yield, and remember white inflammation. Thank you very much. I'm happy to take questions.
Thank you, Dr. Hong.
Hi.
So, Dr. Sangwan, Dr. Swati, Dr. Sayan. We have 2 minutes around for questions. So if any.
Anshing, great talk. Can you just also elaborate on the biopsy protocol and what your recommendations are on what practitioners should do when they suspect pemphigoid, or how to differentiate pemphigoid from other causes of cicatrizing conjunctivitis?
So I mean, as I showed you, they look very similar. And I mean, one of the ways is basically a progression in scarring. So that's very important if you want to diagnose the group 1 diseases, which is either mucous membrane pemphigoid, or that subset of Stevens-Johnson syndrome, or the drug-induced cicatricial diseases. So in terms of looking for progression, fornicule foreshortening is important. A loss of pleca is an early sign of pemphigoid, but of course it can happen in other cicatricial diseases. But you need basically every 3 to 6 months monitoring of the either a phonic step measure or serial photos. In terms of biopsies, I've mentioned I usually take 2 from the bulbar conjunctiva, 1 over the disease area for histopathology, because to exclude other types of cicatricial diseases, and 1 perilesional area where it's basically not less inflamed, and that's for direct immunofluorescence. These need to be snap freezed or put in special media, sent fresh for direct immunofluorescence, and you need a good pathologist to increase the basically to be able to read these type of small samples. And then another biopsy that I'll take normally is from the mouth, the oral mucosa, to increase the yield. Again, I send this also for direct immunofluorescence, whether or not patients have diseases in the mouth.
So, Dr. Hong, the oral biopsy you take for all patients, or only when the ocular one comes negative?
I take for all patients. So normally I just take from the eye and the mouth. Yeah.
Both.
So I just had a question for starting immunosuppression in these pemphigoid patients. Do you do it ever on clinical suspicion alone, or always after biopsy proven? You do it only in biopsy proven cases?
So no, so because of what we found, we do not wait for the biopsy results. Sometimes, if the diagnostic the suspicion is high, we start immunosuppression without delay, because some of these can progress quite quickly. And they are sort of termed the negative, DIF negative or immunopathology negative pemphigoid, as shown in the new consensus, which includes both ophthalmologists and dermatologists. So normally when we start, we don't really go. There is a step ladder. I didn't go through management today, but there's a step ladder approach. But most patients are usually quite inflamed. They usually need mycophenolate. But if they are severely inflamed, they either need IV rituximab, which many of my patients require, and a lot of the dermatologists, they prefer rituximab to things like cyclophosphamide, because of the side effects of cyclophosphamide.
So we have one question in the chat box, probably one last, which we can take. So it's from Dr. Vikas. He's saying, you have mentioned presence in all ages. What is the youngest age you have seen OCP in? And we see in older age and sometimes in young adults as well. Haven't seen in kids. So any systemic issues to be looked for, like oral ulcers, that should be taken seriously, because probably in these cases, early aggressive treatment will be helpful. So your take on this.
So the youngest patients I've seen is they are in the 40s. I mean, it's still a disease that affects the older population, I would say. But I have seen some patients in the 40s. I haven't seen kids with OCP yet. But in terms of the oral ulcers, yes, I always look in the mouth. If there's only suspicion, I always look in the mouth, because the mouth is the one that has the higher prevalence in terms of the disease pathology with pemphigoid, and they are usually affecting the hard palate. Some patients are asymptomatic, but you can see ulcers usually on the hard palate, and that's usually quite a strong indicator that it's ocular pemphigoid, or it's actually pemphigoid. Yeah.
All right. Thank you, Dr. Ong.
Thank you.
So we'll go on to our next presentation. I'd like to invite Dr. Sayan to take his talk.
Okay. So hello, everyone. I hope you can see my screen. Let me just put this in slide share mode. We had a fantastic talk to start off with with Hanxing talking about pemphigoid. We actually originally had um, Haji was going to talk, Hajira Saeed was going to talk on SJs, but she's going to come a little bit later. So I'm going to go ahead with my talk on ocular surface rehabilitation in chronic cicatrizing conjunctivitis. We just heard about what this term means and what it entails. So, put it very simply, chronic means long-standing. Cicatrizing means that there is scarring, and there is scarring of the conjunctiva, which leads to a chronic red eye, which is essentially what conjunctivitis stands for. So, when we say chronic cicatrizing conjunctivitis, we are essentially referring to cases that have long-standing red eye because of conjunctival scarring. So this scarring can manifest in different ways. You can see this as scarring in the bulbar conjunctiva in the different parts, which manifest as symblepharon or medial canthal or lateral canthal fibrotic tissue bands, ankyloblepharon, symblepharon. And more severe cases, you will see essentially the entire ocular surface being engulfed by this chronic progressive inflammatory process, which results eventually in dry eyes, limbal stem cell deficiency, and even dermalization of the surface. So in very severe cases of pemphigoid and Stevens-Johnson syndrome, you'll just find that the entire eye is shut with skin growing over or the eyelids stuck together. So we just heard Hongqing talk about Dr. Dart's classification, and we kind of borrowed from that concept and, kind of revisited all the different causes of chronic cicatrizing conjunctivitis. And this is a long list, but for the ophthalmologist, you can simplify this and cut it down to 4 or 5 major causes. This is data from our center. Between 2019 and 2024, we saw almost 1,700 cases of chronic cicatrizing conjunctivitis, excluding chemical burns, which we deal with separately and don't really consider within this cluster because they have different implications. So SJS was number one with 60%. Ocular MMP was about a quarter of the cases, so very different from the data that Hongxing presented from Moorfields when he was there. SJS, of course, is the more common cause here. Other causes, the main causes were drug-induced, mycoplasma-induced, or post-acute conjunctivitis, what is called RIME, or reactive infectious mucocutaneous eruptions, and then a small percentage of GVHD cases. So as an ophthalmologist in the developing world or in India, you'll probably be dealing with Stevens-Johnson syndrome, mucosum pemphigoid, drug-induced cicatrizing conjunctivitis, and then MIR. These are the 4 main causes that would account for almost 90% of the cases that you'd see. But depending on the geography, one cause would be more common than the other. Corneal damage is what causes blindness. So this is what we are trying to prevent, and this is where reconstructive surgery comes in. It's almost always secondary to either chronic inflammation because of dryness, because of chronic limbal inflammation, which leads to limbal stem cell deficiency, or because of direct trauma to the cornea, because of the lids and because of the eyelashes. So when you talk about beyond medical therapy, Hongxing touched upon immunosuppression, and you can do this topically as well, along with lubrication, which almost you use in every such case. But you're looking at reconstruction either of the lid or the adnexa, which can be in the form of electrolysis, entropion correction, mucous membrane grafting, or in the conjunctiva, which can be in the form of amniotic membrane grafting, which is for something temporary, or conjunctival grafting, or bulbar mucous membrane grafting. And in the cornea, you do visual rehabilitation with scleral contact lenses, SLED, SOMET, and keroprosthesis. So Swati is going to talk about the lid adnexa and conjunctival reconstruction with mucous membrane grafts. Shweta is going to talk about keroprosthesis. So I'm going to talk a little bit about conjunctival grafting, SLED, and SOMET, which comes in between. You must remember, for all those of you who are watching, that corneal transplantation or keroplasty is not a viable option in reconstruction in ocular surface disease, particularly corneal blindness because of chronic cicatrizing conjunctivitis. Keroplasty should only be considered if it's an emergency to save the eye, and should always be performed with a broad central tarsorrhaphy, essentially to prevent the graft from melting. So we have to do all of this and learn all of this because we cannot do corneal transplants in ocular surface disease. This is something that is very widely known, and we should all appreciate and therefore work around this. So just to give you a couple of illustrative examples to take you through how we decide on this decision-making algorithm. Here we have a case which has, this is post-chemical burns, but this could be any case of SJS or pemphigoid which presents with a progressive pseudopterygium. This would, the options that you would have include whether you do SLET or a CAG or a CLA. If it doesn't involve the visual axis, you might not do anything. Wait for it to progress, control the underlying disease. But if it does, then something like this could be very simply addressed by doing something like a conjunctival autograft, or in this case, because this was unilateral and the other eye was normal, we did a conjunctival limbal autograft. So this is where the conjunctival limbal autograft is, and we have been able to address the problem and restore the vision of the patient. The patient has 20/20 vision in this eye unaided. If you have something more complex like this is again post-Lyme burn, but again, just an illustrative example. If it's unilateral, then you have a lot to play with. This is post-amniotic membrane graft, post a couple of sleds, but still with very aggressive recurrent limbal stem cell deficiency and ocular surface disease. Here, you have to address the lid, you have to address the conjunctiva, and you have to address the cornea. So all of three reconstructions have to be done. Here we did ALR with MMG, which Swati is going to talk about for the eyelids, conjunctival autograft 360-degree for the bulbar conjunctiva, and simple limbal epithelial transplant for the cornea, and were able to achieve a good outcome. So understanding what all is involved in addressing each one by one. If you have bilateral limbal stem cell deficient end-stage corneal disease in cicatrizing conjunctivitis, in this case, this is because of chronic AKC, allergic conjunctivitis, atopic keratoconjunctivitis, then you can do bilateral limbal stem cell transplantation. Here we did a allogenic cadaveric limbal stem cell transplant using SLED. But you have to remember that you can achieve such wonderful outcomes and good vision. This patient is 20/25 with scleral contact lenses, but these patients need to be on lifelong immunosuppression, typically either with cyclosporine or with tacrolimus. Just to show you very briefly how this is done, we basically remove the panels just like we do for SLED, and then cover the surface with an amniotic membrane. And then instead of taking the limbal tissue from the other eye, we take the limbal tissue from a donor cadaveric corneoscleral rim, cut it up into small pieces, and just that, like we do for autologous SLED, we put the pieces on the eye with fibrin glue. So the surgical technique of allo-SLED very similar to auto SLED, and you can use this for reconstruction in wet eyes. This is a case of Stevens-Johnson syndrome, where the right eye was wet, the left eye was dry and completely dermalized. So we decided on reconstructing the right eye with a superior mucous membrane graft for the symblepharon, and then living related from her mother for the cornea, which worked out very well. The patient was 20/50 with scleral contact lenses. This is a patient with DICC, with wet eyes, but with progressive pannus over the cornea, losing vision with every month. And again, in this case, instead of jumping directly to a keratoprosthesis, we did a allogenic limbal transplant from a cadaveric corneoscleral limb. Worked out very well. The patient recovered 20/20 vision, best corrected, but over a period of time, the LSCD record and the case failed. And these are cases where we think that we can reconstruct using the oral mucosa, just like you do for COMET, or we used to do for CLED, which later transformed into SLED. This is our latest innovation in terms of SOMET, or simple oral mucosal epithelial transplantation. So again, the surgery is very similar to SLED. You remove the pannus from the eye, but instead of putting a limbal graft after putting the amniotic membrane, you move to the lip as the donor tissue, from where we take tissue in terms of a small strip of the oral mucosa, the lip mucosa, which is cut up into small pieces and again put in place with fibrin glue. And the epithelial cells from the oral mucosa tend to epithelialize the surface. This is the same patient post of day 1. This is after 3 months. We have a stable surface. You can see the blood vessels reaching each of the SOMET transplants and the surface being completely epithelialized. The patient also had a posterior subcapsular cataract, a vision which was not improving beyond 23/20. We did the cataract surgery. And this patient, and the final follow-up visit, you can see here that the patient has an uncorrected vision of 20/25. The surface is very well maintained. The ASOCT still shows that there is translucent epithelium on the surface, not transparent like in limbal transplant, but it's a stable epithelium. It's autologous. It can't reject. And it's a very good option for patients who have this kind of chronic ocular surface disease. And SOMET, in our experience, tends to also work in patients who have some amount of dryness. So in ocular surface reconstruction, The lid part, like I said, Swati will cover. The keratoprosthesis part, Shweta will cover. And in between, you have these options in wet or slightly wet eyes to do SLED, where mostly you will need to do allogenic because these are bilateral, which will require immunosuppression. But what we are increasingly starting to use is SOMET, which is autologous and does not need immunosuppression, and can also be performed in eyes which have a little bit of dryness where you cannot do SLED, which is really increasing the options that we have and the amount of things that we can do for these patients with severe keratopathy and blindness because of chronic cicatrizing conjunctivitis. So I'll stop here. Thank you so much for your attention and happy to take questions.
Thank you, Dr. Sayan. That was a great talk. So, Dr. Virendra Sangwan, Dr. Swati, Dr. Hong.
Yeah, I have a question for you. For SOMET, do you think that if somebody doesn't have superior and inferior fornices, so there's a complete symblepharon formation and there is a corneal panels over there, so would you do only SOMET, or in that case you did combine it with bulbar mucous membrane graft?
We'll combine it with the bulbar mucous membrane graft. So that works out very well because you can take all the grafts from the same place. So we've done several cases. Maria is, in fact, the first case of SOMET that we published was exactly that, where we did bulbar reconstruction with annular mucous membrane grafts taken from the same place, the lip, and then the corneal reconstruction done with SOMET. Where you do not have significant conjunctival cicatrization, you can just do SOMET and you can do customize it based on where the symblepharon is, just like we do for SLED. Sorry, you were saying something.
So I was saying, any differences in your post-operative care for these patients when you're...
Not really. The post-operative care is very simple. We don't really give much. Initially, just for the tissue edema, you can give some steroids, but eventually long-term, they don't even need steroids. The only difference I would say is that because the oral epithelium tends to grow out slightly slower than the limbus proliferates very quickly. The oral mucosa is not as quick. You need to keep the tarsorrhaphy in place for a slightly longer period of time to get the surface to have the opportunity to reepithelialize. The other thing that we have noticed with SOMET, which is also very relevant, and I should have mentioned, is the fact that it doesn't really work as well in patients who are very elderly. So I think that the pemphigoid cohort, for example, is somewhere this is where you probably not find SOMET to be very useful. But as long as you're working in the SJS, within the field of SJS and other DICC, etc., where the patients are slightly younger, tends to work very well. I think the oral mucosa doesn't really grow very well in very elderly individuals, or it has less proliferative potential.
Yeah, thank you.
And can I ask a question, please?
Yeah, please.
And do you, although you just mentioned in the end, when you are talking about LO-SLED or any reconstruction procedures, do you use it as a blanket for all ocular surface disease, or do you make a difference when you are dealing with pemphigoid patient versus SGS patient? Because you may think of doing a lot of immunosuppression, and do you want to use both as you'll just see the symblepharon and do the ocular surface reconstruction, or how much importance do you'll give to the etiology per se?
No, it's a very important point. Etiology is consideration of the etiology is paramount. Pemphigoid is probably the most difficult disease to manage because of so many other considerations, especially the need for immunosuppression and sometimes the unpredictable course after surgery. And so there, the threshold for any kind of surgical intervention is very high. Prevention, and therefore therein lies the importance of what Honching was mentioning in terms of early diagnosis and early institution of immunosuppression to prevent the cornea. So I think a large emphasis for us and the importance, the criticality of diagnosing these patients early when the cornea can still be salvaged, controlling the inflammation, controlling everything else that can be done, giving them clear lenses, immunosuppression to prevent the cornea from getting damaged and getting to an end stage situation where we need reconstruction is of paramount importance. That's number one. But when we get into this situation, then it's really difficult because our options are very limited. With SOMET, we have slightly more avenues now where you can give better outcomes. But still, like you said, pemphigoid is probably the most difficult situation out of all of these things, because even in DICC, which is very much like pemphigoid, If you withdraw the offending medication, at least the inflammatory insult is gone, and then you can proceed with the reconstruction. Also, these eyes tend to be wet. But with DICC, you can have a combination of a progressive immunological disease with dry eyes, which is the worst combination to have.
Yeah. Thank you.
Okay. Thank you, Dr. Sayan. So
Thank you.
we'll move on to our next talk. I'd like to invite Dr. Shweta for her talk on keratoprosthesis.
I'll just share my slides. Are they visible?
Yes, Dr. Shweta.
Yeah. Thank you so much, Dr. Swati and Sayan, for this invite. And the earlier talks have been really interesting, and Sayan has set the stage for me. So let me take you through a few keratoprosthesis cases in the real world, the challenging ones especially. So I'm Shweta from Shankanetralaya, Chennai. And we all know that keratoprosthesis is the last resort for visual rehabilitation in patients who are bilaterally visually handicapped, but they have realistic expectations and are willing for regular follow-ups. Now, before we decide to choose a patient for keratoprosthesis, there's a checklist that we would prefer to go through. First and foremost, make sure that we've ruled out amblyopia, the status of glaucoma, whether the patient had glaucoma, whether it's under control, is there any possibility of a glaucomatous optic atrophy that we are looking at, the posterior segment status, earlier history of retinal detachment, again, will result in a guarded visual prognosis in these patients. The patient should understand the need for lifelong follow-up and the cosmetic limitations that comes with any keratoprosthesis surgery. Now, when we talk about keratoprosthesis, there are primarily two types, the type 1 and the type 2. The type 1, Boston type 1 keratoprosthesis is the parent design, and the variants of which are the Oro-K-Pro and the Lucia type 1. The type 2 most commonly being used are the MO-KP, that is the tooth in the eye, the tibial K-Pro, where we use the the tibial bone, and the Boston type 2 keratoprosthesis, which is similar in design to type 1 with an anterior nub. Now, in the type 1 keratoprosthesis, we are basically looking at eyes which are moist, they have good blink, there is no exposure, and prefer eyes with non-immunological conditions like chemical injury or a total LSCD, aniridia patients, or patients following multiple failed grafts, or a VR surgery with silicone oil-filled eye. These are eyes with really good prognosis in following a type 1 keratoprosthesis. Now, when we look at type 2, we have the MOKP and the tibial, where it's primarily the immunological disorders like the Stevens-Johnson syndrome or the pemphigoid that we've been talking about today, or severe chemical injuries with a lot of adnexal shortening, which even despite multiple repairs, we're not able to get a good phonics. If the patient is an edentulous patient, or the patient has poor oral hygiene, has restricted mouth opening, or has systemic ailments and is unfit for multiple general anesthesias, because OKP requires a 3-stage surgery, multiple general anesthesias, we can always consider the Boston type 2 or the Osteo-K-Pro in such patients. Now, let us go through a few case scenarios. Now, this was a 55-year-old gentleman who presented to us following chemical injury grade 6 of the EPICS classification in both the eyes. He was managed in the acute stage by tenonplasty and allolimbal epithelial transplant. Along with, he had a perforation in the right eye, so he underwent a tectonic PK with an RD surgery. Once the globe was stabilized, 7 to 8 months later, we planned for the left eye type 1 keratoprosthesis. And this is how he is. Vision improved to 6/9. It's been almost 28 months, and you can see a well-integrated keratoprosthesis in an ASOCT. Another patient, a 45-year-old lady from Mauritius, a known case of Stevens-Johnson syndrome for almost 20 years with dry keratinized surface. One-eyed patient, her dental hygiene was okay. So a perfect candidate to go in for the OKP in the left eye. Vision improved to 6/6 post-operatively and has been maintaining the vision for last 17 months. Another young male following a chemical bilateral injury and industrial accident, one-eyed. The right eye, when he presented to us, had a granuloma but had an epithelialized surface, significant inflammation causing a diffuse choroidal thickening and an axial length of only 15. So we started him on oral steroids, waited for a few months, let the globe settle, let the inflammation settle down, when the axial length also increased to 20.9. And this is when we decided to take him up for a Boston type 2 keratoprosthesis. Now, in view of the hypotony that the patient had, we deferred an AGV for him, which is routinely combined with the Boston type 2 keratoprosthesis. So always customize your keratoprosthesis based on the ocular parameters that the patient presents to you with. He went through a Boston type 2 through the lid and is now maintaining a vision of 636 for the last 18 months. The case 4 is a patient who had undergone an MOKP procedure almost 7 years back and has been maintaining a vision of 618 following a chemical injury, but had uncontrolled pressures. We had already put 2 tubes in his eye and had undergone diode CPC earlier. His disc was around 0.8:1. But for the last 1 year, we were noticing an uncontrolled pressure again. OKP, topical anti-glaucoma medication absorption, is a little borderline. He was on oral acetazolamide, which was increased, but the IOP was still high. So we were going to plan for an AGV exploration along with an endo-CPC. But what we noticed was an increased protrusion of the optical cylinder, and the CT scan, if you see, very clearly shows an increased resorption in the lower end. So which is why we decided, spoke to the spoke to our glaucoma specialist and decided to wait for 3 months, step up the intraocular, Diamox or the oral acetazolamide, plan for his second tooth so that we don't have to wait and, keep him without vision for a few months. So this is what we did. We started preparing for his tooth. We underwent a one more stage 1C and prepared the other tooth, kept it in the cheek for vascularization. And exactly 3 months later, he presented to us with a leak, a perfect time to replace it with the secondary lamina, which was already ready. Now here the plan was, if we go ahead and explore the tube and we remove the keratoprosthesis, there is a possibility that the opening might increase and there is hypotony. So we kept a penetrating keratoplasty also ready at this stage and decided to go ahead with a type 2 1 month later, which is exactly what happened. When we were doing it, there was significant hypotony because the glaucoma consultants were doing an AGV exploration. And so we placed the cylinder 1 month later. And 6 months now, he's been maintaining a vision of 618 with finger tension being normal. The last case, a 45-year-old patient with SJS, again, who underwent OKP 2 years back. The tooth was, to begin with, not a very good tooth, but patient was extremely keen for OKP, so we did go ahead. He was maintaining a vision of 6.9, came to us with diminution vision since 3 weeks. There was a total retinal detachment with a lamina exposure. Now we went ahead, we were going to remove the lamina, do the RD surgery, which was going to require a temporary keratoprosthesis. Based on the status of the lamina intra-op, we decided whether we will go ahead with a K-Pro swap or we will put the same lamina back. So this is how he was intra-op. When we removed the lamina, we closed the opening with a 4 millimeter scleral graft. And you see there was a significant lamina resorption, though the optic-haptic junction was maintained. So we placed a temporary keratoprosthesis of 8.2. The retinal colleague went ahead with settling the retina. And since there was a significant lamina resorption, this time we replaced it with a Boston type 2 keratoprosthesis through the mucosa. So it's been 10 months. He's been maintaining a vision of 624 following an RD surgery. To summarize, K-Pro surgeries have their own challenges and they require case-based surgical modifications, which again brings us to a very important aspect of a pre-operative planning. Again, nothing of this is possible without a team approach, and only then can you have improved outcomes and smiles on these faces, which are precious than I don't know what. This is our SN keratoprosthesis team. So it includes everybody, right from our secretarial staff to our OT staff, to nurses, to our cornea fellows who are the spine of the department, to Varsha Mukundan, my colleagues in the Ocular Surface Clinic, our VR consultant, anesthetist, and glaucoma consultants. This is our YouTube channel, Ocular Surface Gurukul. Do explore for ocular surface surgeries. Thank you so much.
Thank you, Dr. Shweta, for sharing those complex cases. Dr. Sayan, Dr. Vikas, Dr. Jayesh.
Yes, wonderful talk, Dr. Shweta. I just had one question about the trends. So there were some papers recently which seem to show that the number of K-Pros done globally went up during the, let's say, after 2010 to 2020, and then have steadily been falling. This may probably be due to better management options being available for certain situations where you no longer now need to do a K-Pro. So is that also reflected in your numbers at SN, and how are the trends at your center?
So Dr. Jayesh, actually, since we are a referral center and we primarily run an ocular surface clinic where we specialize in keratoprosthesis surgery, we haven't noticed a dip in the number of patients being referred. In fact, I was just sitting with our data for the last couple of years when, since the new team has come up. But in the last 2 years, we have done almost 45 keratoprosthesis plus 7 to 8 OKP. So around 50 plus is the number that we have done in 2 years. So I don't think that, as a tertiary reference center for keratoprosthesis, I can make that comment, but I completely agree with you. Since there are better modalities of treatment and diseases are being understood better, they are caught early in the stages. I think a lot of these can be avoided. And after the stem cell transplant in wet eyes, I think it's been a game changer. So yes, I agree with you if there is a global trend of.
Thank you.
Shweta, so do you, since there will be ocular surface surgeons and cornea surgeons watching this webinar, so do you want to give any pointer on the algorithm? When do you choose type 1, when do you choose type 2, and when do you choose MOKP, so that it is clear that how you're choosing? You've shown this beautiful surgery, and we have been seeing the patient surgeries all these years, and remarkable work, no doubt. So maybe a quick pointers on how you select will be helpful.
Very good question, Dr. Vikas. So type 1 keratoprosthesis is an eye which you would have otherwise thought of doing a straightforward penetrating keratoplasty. So the eye would look absolutely normal, like for any PK eye. So the eye would have a good blink. Schirmers would be good, more than 5 to 10. The eye is absolutely moist. And the primary pathology that the graft is going to fail is either there is a total limbal stem cell deficiency, it's an oil-filled eye, so the graft is going to decompensate. It's a chemical injury, it's a multiple already failed grafts. So these are eyes which are perfect for a type 1 keratoprosthesis. You have no underlying autoimmune disorders like SJS or OCP, where you would prefer not to do a type 1 keratoprosthesis. Now, moving on to type 2. So all these immunological conditions like your Stevens-Johnson syndrome, cicatricial pemphigoid, severely dry keratinized eyes are eyes where you would prefer a type 2 keratoprosthesis over a type 1. Now, we personally have been preferring the OKP. The reason being the longevity of the keratoprosthesis that the studies have shown till now. We do not really have a 10-year, 15-year data for the 15-year data for the Boston type 2, but I feel it's a beautiful keratoprosthesis and can be used equally. So if the oral hygiene is good, if the patient is young, if the patient has fitness for general multiple anesthesias, he can be a good candidate for the OKP. If the patient is a little older with fitness issues for general anesthesias, you're not really sure about the visual prognosis, patient has had an RD earlier, and you're not sure whether the vision will improve or not, then in those cases, you can just go ahead, do a Boston type 2. So because it's a single stage surgery. So these are broad guidelines where, you can pick and choose.
Yeah, thank you so much. So which means it's a wet eye, then you tend to prefer type 1.
Yeah, sure.
Thank you, Dr.
One had a
Shweta.
question for you. Onching had raised his hand. I think he has a question for Shweta.
Oh yeah, actually my question is the same as the previous one. So because many centers do not offer MOOKP or OOKP now, so it's just it's basically the different when do you choose OOKP versus your type 2 K-Pro? So it's basically similar to the last question. It's basically the limited availability or accessibility to OOKP. Do you have any comments on that, Shweta? Otherwise, it's very good talk and very good surgery.
Thanks, Ongching. I think I partly answered that question with Dr. Vikas. So yes, I think training is an important limiting factor for the OKP. And I think it's also because it's a long duration surgery that the number of centers which are going in for the OKP are a little less. But the long-term outcomes that have been reported are the longest with the OKP. So I think it is a good surgery. And I really hope that keratoprosthesis surgeons get more motivated, and we have a wider training thing, which we ourselves at our center have been looking at. And we are planning to have a fellowship especially for keratoprosthesis coming up soon.
Thank you, Professor. Thank you.
All right. Thank you, Dr. Shweta. So I'd like to invite Dr. Swati to go ahead with her talk.
Thank you, Maria. Can you see the slides?
Yes, Dr. Swati, your slides are visible.
Again, good evening, everyone. So I am Swati Singh, and I'm fortunate enough to be trained in both ocular surface and oculoplasty from LV Prasad Eye Institute, where I currently work. So I'm going to take you through 3 clinical scenarios that we very frequently send our patients to our plastic colleagues for in these patients, which is symblepharon, entropion, and then eyelash malpositions. I'll begin with cases. Here you can see is a young girl who has a congenital upper eyelid coloboma. So she has a deficiency. She has a symblepharon in the supranasal quadrant. And now the symblepharon is fusion of the eyelid with the ocular bulbar surface. So there's a deficiency on both the corneal and the conjunctival side as well as on the eyelid side. Now, unfortunately, what happens is for our oculoplastic colleagues who have not really worked with ocular surface team per se would typically do amniotic membrane grafting for the conjunctival part in these eyes. And this patient had already undergone surgery elsewhere, and you can see an aggressive symblepharon formation in the superior part, which is not the congenital presentation. You can see scarring in the superior corneal part as well. So in these cases, when you have symblepharon formation, the deficiency on the bulbar conjunctiva should be replaced with a conjunctival autograft. So in this case, we did upper eyelid reconstruction using Tenzel's flap, and we repaired the conjunctival defect with conjunctival autograft. So in symblepharon and ankyloblepharon, if you have access to the conjunctival tissue, then that is the best replacement for these deficiencies. Many times you can have complex scenarios. This is an individual who had a chemical injury and had an associated upper eyelid ptosis, and he has undergone already PK and slit in the past, and he has symblepharon in this area where you can see a pyogenic granuloma in this place. So because of the repeated surgery, he had already, allogen implant was used in this bulbar surface to prevent the fibrosis and recurrence of the symblepharon. And patient had undergone only AMT and use of mitomycin C as well. And we clubbed both the symblepharon repair as well as the ptosis correction in this patient. And here you can see the eyelid is opened up well, and that area which had pyogenic granuloma now has a healthy conjunctival epithelium over this. So in eyes where you have access to the other eye is normal, if it's a unilateral scenario, then you use conjunctival autograft. In cases when it's bilateral scenario, like in this patient, she was a 9-year-old girl who had Stevens-Johnson syndrome sequelae in both the eyes, and this is her right eye, and both the eyes had a similar appearance. So I definitely cannot use a conjunctival autograft to repair it. So next option comes is we use mucous membrane graft, which is harvested from the oral cavity. So in this, first you release all the adhesions, you expose the bulbar surface, the sclera and the conjunctiva, remove all the fibrotic tissue, and then you expose the recti muscle. Here I have marked it with asterisk, where you can see inferior rectus is being exposed. Now the reason for this is that we want you're going to use a big graft in the inferior bulbar area, and you want it to get vascularized, and the surface is completely scarred. So those new vessels are not sufficient enough to make your graft survive over there, and there are no healthy epithelial cells in this surface which can take care of the survival of the graft. So in these cases, we anchor the graft onto the recti. So we use, here you can see the marked area where I have placed a mucous membrane graft on the bulbar surface, where you anchor it to the underlying sclera with 7 or 8 zero-vicarial sutures, as well as to the underlying recti muscle. And then we have placed a small part of mucous membrane graft on the eyelid defect as well to prevent the recurrence in the inferior part as well, so that there is enough space for your scleral lenses to fit in. And this is 6 months follow-up of this patient, where you can see the marked area shows a little increased vascularity is the area where the MMG has been taken up. And now she can easily, comfortably wear scleral lenses, PROS lenses, and has been rehabilitated for the vision part. Similar another case, a one-eyed patient who has only left eye as a seeing eye, but the vision is only counting finger close to face. We want to give a trial of scleral lens, but there is no fornicis to fit. The inferior fornix is completely stuck onto the bulbar surface, and there is a complete keratinization in that area. So in this case also, we did mucous membrane graft, which we have placed both in this superior upper semicircular quadrant as well as the inferior semicircular quadrant. And here you can see that there's enough space to wear a Prose lens now, and with the lens his vision has been cleared to 20/200. And somehow I feel that with this, either maybe it's the way that Somet is working, but if you place your mucous membrane graft near the limbus, that corneal clarity improves a little bit in these eyes. This is a publication where you can read more for the detail about the surgery. Next comes the entropion. Cicatricial entropion in these cases is multifactorial. So they have extensive scarring on the surface. They have dry eyes, so they cannot really open up their eyes, and they'll have spastic component as well. And then they have lid margin disease, here seen as keratinization of the lid margin, which keeps rubbing onto your ocular surface and induce the corneal damage. So in these cases, if you do a simple procedure of just using, if your colleagues do anterior lamellar repositioning or tarsal margin rotation, that alone itself is not enough. You will, in my hands, I've seen you will end up with 100% recurrence. So we have now started doing this technique where we use mucous membrane graft along with entropion correction of the upper eyelid. So in this, first you split the anterior and posterior lamella. Then you take the anterior lamella a little higher up, 3 millimeters from the lid margin. And then you use this graft which covers your exposed surface of the tarsal plate, the lid margin, and a little bit of the posterior upper tarsal conjunctiva. So I'll show a quick video of patient who had SGS sequelae, has already undergone mucous membrane graft and electrolysis in the past, and now she has a entropion, cicatricial entropion. So in this, first we mark the labial site and infiltrate it with the lignocaine adrenaline combination so that there is less of bleeding when you're harvesting the graft. Then you move on to the eyelid part where you evert the upper eyelid, and then you split the anterior and posterior lamella with 50 number surgical blade. In this, we dissect it completely so that both the anterior and posterior lamella are completely separated. Make sure that you don't cut into the tarsal plate and your plane is accurate. And then we give 2 relaxing cuts vertically at the medial and the lateral end of your incision. And then you recess the skin. I'm taking a partial thickness bite through the tarsal plate because I'm going to reposition the skin margin little higher up so that lashes are away from the surface. And then you place 3 sutures, medial, central, and the lateral one, and then close those vertical cuts also. This is the mucous membrane graft which we have harvested. Now you can see it has a lot of fat and some mucosa to it, but you want to cover the graft. The graft thickness should be similar to conjunctiva, so you don't want it to look bulky on the lid margin. So you remove everything which is yellow and shiny, which is fat, and then you make it thin. Then you place it in that defect which you've created, and you use 7 or 8 vicryl to suture it to the lid margin. You can use continuous or continuous interlocking sutures, and use glued for the posterior surface. And this is how it looks on post-op day 1. It's well pinkish vascularized, and this is a sharp posterior lid margin. This is another case which has been again managed with the same technique, which had already undergone electrolysis setting multiple places and routine anti-lambda repositioning. Now we have placed a mucous membrane graft, and the patient in long-term follow-up is doing very well. We can use it for segmental cases also. Like in a kid, the rest of the lid margin is absolutely healthy. It's only the medial segmental entropion. So you just correct that part which is involved along with an adjacent 1 to 2 millimeters of healthy eyelid margin. And they do well in, at least we've seen in long-term follow-ups. Now, another scenario which we come across is these misdirected lashes, and we use electropilation for these. And in some, unfortunately, in these patients with cicatrizing diseases, it has a very high rate of recurrence to the tune of 50 to 60%. So I always tell my patients, if you have 6, I do it only when they have 4 misdirected lashes. So if you have 4, the 2 can still come back, and then after 2, the 1 can still come back. So why it happens is because it's a blind procedure, and we do not know how deep the needle should go. And what we do in this is we burn this eyelash bulb. Now, this is a site which contains stem cells. So unless your current reaches that area, the eyelash is going to grow back. So we did this study where we examine the eyelids for the eyelash depth as well as the direction. And then we have come across for the Indian eyes, the depth we need in the upper eyelid is 3 millimeters and the lower eyelid is 2.2 millimeters. So we use this technique now where we pre-mark the 29 gauge needle. So the upper eyelid I have taken 3 millimeters. Then you go along the misdirected eyelash and then you touch your electrocautery current to this tip and you wait for the discoloration of this lid margin skin. And once that happens, you pluck it off. If it easily comes off, that means the application is successful. So to summarize, I think I have worked on both the sides in oculoplasty as well ocular surface, and I feel that there is a need of more, dialogue between the two specialities for the better outcome of the patients. And despite patients who have undergone repeated surgeries, if we carefully plan our surgical approach and understand the need for the surgery, then we can still achieve good outcomes. Thank you so much.
Thank you, Dr. Swati, for showing all the cases and the simplified version. In fact, even I have learned from your surgery. So you've really simplified the technique of correcting the entropion along with addressing the cicatrizing component. So, and the lid margin keratinization. So we have Dr. Hajra Saeed who is joined. And I think in view of, since we are a little short of time, if it's okay, we can have the questions of both the sessions together at the end. Is that all right?
Yeah, absolutely fine. You can.
And there's a little bit of overlap between the two, so I think that'll work out well. Let me share my screen here. Good to see everybody today. Can you see my screen here?
Yes, we can see you, Haji. Go ahead.
Great.
Welcome.
Okay, thank you very much. So I'm going to focus on select ocular management in SJS-TEN with a little bit more of a focus on acute disease, which I'm grateful for, since it looks like a lot of chronic disease was already covered in this session. Now, is my screen advancing? Let me see. Okay. Now, this is why we care about SJS as ophthalmologists. Many of you have probably seen photos like this, and maybe even this one in particular before. My mentor, Dr. James Chodash, and colleague now, had provided this photo of one of his patients with just complete ankyloblepharon, keratinization, complete xerosis of the ocular surface, and very severe chronic complications from SJS. And an eye like this obviously cannot function and needs some very extensive management, and a lot of which is precarious. And even after having intense management, we don't know what the visual outcome in a patient like this would be. And so our focus really is on getting appropriate acute care to reduce the chances of severe complications like this. Now, in the United States, where I'm based, complications to this degree are relatively rare. But based on my conversations with colleagues in India and other parts of the world, it seems like complications and presentations such as this are not so uncommon, and it's really quite devastating for the patient. And the most significant chronic sequelae in survivors may be of the ocular surface. As you know, SJS is a fatal disease with fatality and mortality rates approaching 30 to 40% and even higher in patients with compromisation. And so in patients who do survive, the ocular disease is really what becomes very life-altering. And the ocular surface is affected in up to 100% of patients in the acute phase and 70% in the chronic phase. And as survival improves, this is more based on US data. I'm not sure how acute survival rates are doing in India and other parts of the world, but survival is continuing to improve year by year, decade by decade, with better supportive care in the burn unit setting. And so as we have more survivors, that means there are more patients which are going to have chronic ocular disease, and it's more commonly seen. And ocular disease may be a major contributor of PTSD, post-traumatic stress disorder, and effect on quality of life on its own, regardless of other manifestations that occur in SJS, which are also severe. So a brief outline of events from acute to chronic. You can see here, and for the sake of time, I will skip over some of the text and talk to you about the images that we see here. We can see the acute stage, highly variable. You can have just hyperemia of the ocular surface and lid margins to sloughing of the mucous membranes of the ocular surface. You can see a pseudomembrane here in the inferior fornix, a corneal epithelial defect that is highlighted by fluorescein here, and then ulceration and denudation of the eyelid margin. This is a little bit of a blurry picture. It's sometimes difficult to get pictures at the bedside, but you can see here that there is diffuse staining and ulceration of the eyelid margin. And these various forms of acute disease can lead to very significant chronic disease in the form of ankyloblepharon, ocular surface xerosis, keratinization, complete limbal stem cell deficiency. And in these cases, very significant interventions need to be taken in order to visually rehabilitate the patient, many of which my colleagues have spoken about earlier in this session. A brief overview of pathophysiology of SJS-TEN in regard to just the lid disease. So even in cases with modest damage in the acute phase, the key risk factor really appears to be a disordered eyelid margin anatomy. And Dr. Swati had just gone over some of those. And of these, it's really the posterior eyelid margin keratinization that appears to be responsible for the most severe disease and for prognosis in SJS-TEN. There are some new data that I have highlighted in red or with a red arrow. There does appear to be drug-related severity. So we have seen anti-epileptics, particularly lamotrigine, to be responsible for more severe acute and chronic ocular disease than other drug classes. This is an area that we are actively studying, but this is based on some of our preliminary data. Briefly, there is systemic treatment that can be undertaken in the acute phase, largely in the burn unit with the collaboration of our dermatology colleagues. And these involve corticosteroids, IVIG, cyclosporin, and TNF-alpha inhibitors. Again, for the sake of time, I won't go into detail. Most of these have equivocal data anyhow. There is not a very definitive benefit of systemic treatment for ocular surface disease. However, there does appear to be promise with TNF-alpha inhibitors. There was a study out of China with our ophthalmology colleagues looking at post hoc data from some of their prospective trials for etanercept. And they found significant improvements in ocular surface disease with systemic delivery of etanercept. Again, something that needs to be further studied prospectively since this was post hoc data, but that seems to be the only immunomodulator that may have really significant effects on chronic ocular disease. I will say that our colleagues in Japan do use pulsed high-dose steroids in the acute phase that appears to have significant effect on disease as well. We have not seen that in the United States. I think there's many variables that account for that, including access to care, time to access to care, and I'm sure that there's a demographic background to this as well. Importantly, for the pulsed high-dose corticosteroid, that was given within 3 to 4 days of disease onset. So if the patient is not seen within that onset, and many times in the US that is the case, by the time they get to a tertiary care center that can deliver the care that they need, they may be out of that window where they're able to benefit from that therapy. So these are all investigations that are ongoing. Now, in terms of acute ocular management specifically, so not systemic therapy, but topical and targeted ocular surface therapy, we divide cases into grade 0 to grade 3, which increases in scale based on severity. And you can take a photo of this or look into this further. I will give you the reference in just a minute, but it involves lubrication of the ocular surface. MF is moxifloxacin, antibiotic, fluoroquinolone, given 3 times a day, prednisolone acetate 6 times a day, fluorometholone ointment, also given to the lids and ocular surface, along with intense lubrication. Now, in grade 2 or grade 3, which really involves defects of the ocular surface and eyelid margin, we include amniotic membrane transplantation. And I will talk in more detail about the different techniques for that. Importantly, amniotic membrane comes in different forms. So you can have a Procara ring, which has the amniotic membrane stretched over a symblepharon ring, or a full sheet of the amniotic membrane. It is really important to note a full sheet of amniotic membrane must be used, particularly when there is eyelid margin disease, because the Procara ring, it does not cover the eyelid margin. It only covers the ocular surface and the surrounding limbus. So if the disease is contained to the cornea, and the surrounding conjunctiva, or you're not too concerned about the other areas of the bulbar conjunctiva involved, then you may be able to use a Procera ring. But if you have fornicele involvement or eyelid membrane margin involvement, you need to use the amniotic membrane sheet because that is the only thing that will allow coverage of the entire ocular surface from superior to inferior fornix. So we looked at our data, pre-amniotic membrane and post-amniotic membrane, and we found really stark differences in the visual outcomes in patients who received protocol treatment that included amniotic membrane versus those who did not. And you can see the numbers of patients who maintained vision greater than 20/40, significantly different between the two, and then also patients with vision less than 2200, significantly different between the two. Now, by the time we filtered out all these patients and the length of follow-up that we had, at the end, we had no patients with vision less than 2200, but in actuality, in practicality, when you don't have all these filters and you're not doing just studies and you're looking at the patient in front of you, we do see patients that have severe visual compromise even after they get amniotic membrane transplantation, but still the differences in outcomes are stark. And so we incorporate amniotic membrane in acute treatment across the board. So AMT was first described in 2002 by Thomas John in the use of acute toxic epidermal necrolysis. And in that case, it was used within the first week of diagnosis in patients with moderate to severe ocular involvement to reduce chronic ocular disease. And then it was really popularized by Darren Gregory, where the first 10 consecutive cases were published. And then there was a randomized trial, which is the only one in SJS in regard to amniotic membrane, which showed a significant benefit of amniotic membrane as well. But there have been changes over time. So initially, the amniotic membrane sheets used to be sutured together. So you used to take two sheets, sew them with Prolene suture. It was a back-breaking procedure. Under the burn unit hoods was you're sweating bullets, back-breaking, trying to put these together. It took an hour and a half probably to suture them together. And then a 5 by 10 centimeter sheet was developed, at least in the US. I think there is maybe some more customization that occurs in India, where larger sheets have probably been available for a longer period of time. But we now use these single sheets, so now we don't have to suture them together. And then we went from suturing along the limbus to eyelid bolsters. So you can see here, this is a patient with acute SJS. The amniotic membrane is secured with bolsters to the superior eyelid skin. Amniotic membrane is draped over the surface, a symblepharon ring is inserted, and then the inferior margin is secured with amniotic membrane. But there's some limitations with this. This procedure largely needs to be done in the operating room in acutely ill patients. And because of that, the time to procedure can be delayed. The length of the time for the procedure is also still significant. And there's a lot of tissue manipulation, which can result in pain and bleeding. Although it has really had really significant outcomes in improving visual acuity and chronic ocular disease, there still are limitations. And so we have developed a different technique that involves the use of glue. So in this case, we use cyanoacrylate glue instead of sutures to secure the amniotic membrane to the eyelid margin. You can see that here. It's secured for about 30 seconds to a minute to allow that glue to dry. Symblepharon ring is inserted, and then again, the glue is secured to the inferior eyelid skin. Very similar to this, but without this the bolsters. And we importantly use cyanoacrylate glue. You cannot use Tecile or any other forms of fibrin glue. It will not adhere well enough to allow significant effect on the eyelid margin and ocular surface. The cyanoacrylate glue, however, does really stick to the surface well. But as we know, because we use them commonly in corneal perforations, the glue is toxic to the surface. And so you have to really make sure that the glue does not get onto the ocular surface and it really stays on the eyelid skin.
Dr. Hajra, if I can just interrupt you, we've overshot time.
Okay. I am going to finish up here by just looking at the chronic ocular results between the amniotic membrane suture and glue groups. And you can see really significant similarities in the development of severe ocular complications, as well as maintenance of best corrected visual acuity. So really highlights the significance of using amniotic membrane for acute Stevens-Johnson syndrome. Thank you very much.
Thank you. That was a great talk and a new technique of attaching the amniotic membrane with cyanoacrylate group. So thank you. Any comments, questions for Dr. Swati as well as Dr. Hajra Saeed? Dr. Jayesh, Dr. Sangwan, Dr. Shweta.
Just an observation that I'm passing on from my the dermatologist that we work with. Of course, it was a lovely talk by Dr. Saeed about management of acute SJS, but our dermatologist somehow keeps on insisting that we don't give moxifloxacin eye drops to these patients because apparently they've come across cases of SJS secondary to use of topical moxifloxacin. I also came across a couple of case reports, but nothing that I have seen or I have heard of in a large number. Any experience either you may have or any of the panelists with this?
Yeah, that's a great point. And actually, interestingly, I was recently involved as a medical expert in a case of topical fluoroquinolone eye drops resulting in SJS. So it can occur. It's not common by any means. It's a rare component, even of the rare subset of SJS. But if a patient has SJS as a result of a fluoroquinolone antibiotic, yes, we should not use the topical moxifloxacin. But if that's not the case, the chances of cross-reactivity are really zero. And between classes of different medications, there really should be no increased risk, the same baseline risk as the general population. So there's always going to be that like some percentage of risk. It's not going to be 0%, just like with any intervention, but there should be no increased risk unless they have a previous hypersensitivity reaction to a fluoroquinolone.
Thank you. So to put that into context, we often deal with situations where we are not sure about the chronology of events. And all the drugs that the patient has had prior to the episode of SJS are not very clearly documented. That is more often the case than not. So that is why probably the dermatologists are being more cautious.
Yeah. I mean, if that's the case, other topical antibiotics can be used, but there's still going to be the chance, even with those, particularly the ones with maybe a sulfa component. But I understand the perspective.
Great talk, Hajira. So, any comments about managing these patients in the acute stage? Because we saw a couple of your patient pictures where, so what has been your experience about, what are the difficulties that you faced while managing these patients in the acute stage? Like if you get access to them.
Yeah, the greatest difficulty is the burn unit actually recognizing that all patients with SJS, regardless of how much ocular involvement they think they have, should be seen by an ophthalmologist. That has significantly changed over the last 10 years. Now, I would say the vast majority of burn units in the US do consult ophthalmology. So at least that barrier has been broken. We've done a lot of education with our burn unit and dermatology colleagues, and I think they really recognize the need for that. That's the first barrier. The second is access to amniotic membrane. So here we do not actually process the membrane in the facility. I think like at LVP, for example, I saw that they do it there on site. I'm not sure if that's the norm across India, but that's not the case in the US. And so it has to be in stock and preserved and prepared in a certain way. And certain hospitals just don't have access to that. And we've actually had patients transferred, airlifted from one burn unit to another because they just didn't even have access to amniotic membrane. So those are probably the two largest barriers. But once those two are overcome, it's really about education of our ophthalmology colleagues and getting the residents and fellows involved. I mean, those are the front lines, right? The residents and fellows are the ones who are mostly seeing these patients when they first come to the unit in the middle of the night at acute presentation. The education and implementation has to start there because the procedure itself, particularly the glued one, it's quite simple. I mean, the videos that you guys showed earlier, I mean, those are much, much more complex and involved. And the fact that we can do something so relatively simple to prevent really significant disease is pretty remarkable.
Great points.
Wonderful talk. Very nice to see you, Haji. Dr. Sangwan
Always
here.
good to see you, Dr. Sangwan.
Yeah. Any other question, comments? Or any questions from audience, Maria?
No, Dr. Sangwan, no questions from the audience as of now. We
Lovely.
already addressed a few earlier, so I think that.
All right. So shall we close, or there are any other rituals or formalities that we need to do?
Sure, sir. We can close with a note from you, sir.
No, I just would like to thank everyone for the wonderful talks, and both of you, Maria and Zolika, for providing the excellent support. I think there are very important points that are highlighted by different speakers. The Haji's, acute SJS management. Swati's about, the overlap between the oculoplasty and the ocular surface. I think if we can develop a field surface plasty as a area of expertise for people who can manage these complex disorders, that will be fantastic. And then Hon Singh and Sayan talking about management of immune disorders and cicatrizing conjunctivitis. I think the whole spectrum covered very nicely. And I definitely learned a lot. And Sweta's simple videos of complex K-pros is always a treat to watch. Thank you each and every one of the speakers for enhancing our knowledge. Thank you. Rolika, over to you.
Thank you so much, everyone, for a wonderful session. Thank you, Maria, for coordinating the session beautifully. And thanks to all the faculty members who joined from India as well as internationally. Thank you. As we prepare for the next session in this hall, I request the session coordinators for this session to please take over. You can share the screen from your end.
Hi, Rolika.
Hi.
Hi, Rolika.
Dr.
Thank you so
Aditi and
much.
Dr. Pratima. Yeah.
Hello. So I hope all the people from the next session has joined.
Let me just check.
Yeah. We can ask them if anyone wants to share their slide, check their slides first.
We have Dr. Pooja here, so she'll coordinate with everyone. Dr. Pooja. You're not audible, Dr. Pooja.
Hi, good evening. Good evening, Rolika,
Good
Aditi,
evening.
Pratima,
Good
and
evening.
everyone. Thank you for joining in.
Pratima, would
Hi.
you like to share the
Hi, good
PPT
evening.
or should I?
I
I
can,
sent you the
yeah,
text.
you can go ahead and share. Yeah.
Okay.
Hi, Pooja.
Hi, how are
Yes.
you, Professor Shiham?
Hi.
Pratima, there's no
Hello,
issue. You
Professor
go ahead,
Antonio.
please.
Hello, Professor
I'll share.
Christopher.
Hi, Pooja.
Hi.
Guys.
Nice to
evening.
see you all
Antonio.
online.
Nice
So
to see you.
are the slides visible now?
Yes.
Yeah, perfect.
Yes. Okay. So I think
I think we still have 3 minutes, so
yeah.
Yeah, I
Yeah.
think it's 7:30, right?
yeah.
Yes, sir.
Very good.
Does anyone want to share their slides in the meanwhile and check their slides?
May
Yeah,
I
and just for
share my
everyone's
screen?
information, we are already live.
Good evening.
Okay,
Very good
thanks,
evening.
Rolika.
Good evening.
Hello.
Professor Shafiq, good evening. Very good evening. How are you?
Shetty, how are you?
All good,
Hi,
all
Dr.
good.
Dr. Shetty, how are you?
Very good, Shyam.
I'm good.
So you said you have a
Yeah.
what time do
I
you
have
want to?
a clinic now. I will start the clinic right now, but because I'm starting, Dr. Shafiq will moderate the session with you if you don't mind.
No problem. No problem.
Hi,
But
Christoph.
you can
How are you?
introduce Dr. Antonio and Christopher Burden, so you know them well, so that then the moderators, the panelists, Dr. Pooja will introduce. It's okay?
Okay, perfect.
Hi everyone, so nice to see everyone.
Hi, Pragya.
Hi.
Hi.
Hi. Good evening.
Hi, Sushmita. Hi.
Hi.
So I think we will wait for just 1 more minute and then we'll go.
Yes.
Is it possible to check that I can share my screen?
Yeah, yeah.
Yes,
So
yes.
I'll stop
Yes, sir,
sharing
please.
my screen. Okay. Yeah, you can go ahead.
Okay, just to be sure. Yeah. Because I am the first presenter, so it's very important to check it. Okay. Is it good for you?
Yeah, yeah, absolutely. Perfect.
On slide mode? It's
Yes,
okay?
yes,
Okay.
perfect. All ready.
Okay, perfect. So I
She-
understand now.
So
Uh,
7:30, so we are ready to start now.
Yeah.
So for this
Yes, sir.
wonderful session, which in collaboration with the Dry Eye Ocular Surface Society, we have as president of this society, Dr. Shyam Nazwick is here. And she also, with her, we have a excellent set of panelists who are also been part of the DIOS and also the TFOS and many other important societies. Joined with panelists with Dr. Pooja, Dr. Pragya, Dr. Sheetal, and Dr. Susmita Shah. All of them, I think, have joined. And we have two international speakers, Dr. Antonio and Dr. Christopher Borden, both extremely accomplished ocular surface experts. And also, we have a bonus of having Professor Mohammad Shafiq joining us from Alexandria University to help us in moderating this session. And he also is the co-founder of this society. Dr. Shyam, would you be the chairman of this session? Would like to introduce our two friends to our society here.
Yes, thank you, Dr. Shetty, for the invitation and for organizing this nice session. On behalf of the DEOS, the Dry and Ocular Surface Society, we welcome you in this session, and we will try to have a nice talks and a nice discussion more than the talks. It's my pleasure to introduce Professor Christophe Baudouin, who is a pioneer in the world in ocular surface disease. He's also a glaucoma specialist. And in ocular surface, he's my mentor, and he learned from him since 30 years about ocular surface and the effect of preservative on the ocular surface. And it's my pleasure as well to introduce Professor Antonio Di Zazo from the Roma University. He's also a very renowned ocular surface specialist and cornea specialist. And this is really my pleasure to share with them this session.
So
Do you
can
hear
we have
me?
Can we have the first talks then? Dr. Christophe Baudouin, could you like to start your presentation on neuropathic pain?
With pleasure. Thank you very much for the invitation. Let me just share my screen and check with you that it's correct. Is that okay for you?
Yes, perfect.
Sure.
Okay,
Sure.
thank you very much. Thank you for the invitation to talk about the transition between dry and neuropathic pain. There is a lot of literature, a lot of interest in neuropathic pain. That is a concept that emerged approximately 15 years ago to try to better understand or explain those patients who were complaining a lot and suffering a lot, despite the fact that their ocular surface seems to be normal. And this is a key question about the definition of the transition between dry causing pain and pain that would be independent from dry. My financial disclosure. Let me start with the clinical presentation of a relatively young man who experienced LASIK several years before and who was complaining a lot and suffering a lot, despite the fact that the LASIK was perfect and the cornea looked quite fine and normal. He started different types of treatment without success. Here is the video of this previously myopic patient. And the major characteristic is you can observe pain with no stain. And right now, it's considered that pain with no stain is one of the definition or clinical and practical definition of neuropathic pain. I'll let you look at the video. In fact, if you well observe the ocular surface, you may observe different aspects. And tear film instability, no keratitis, the problem with the flaps, scleral show, incomplete blinking. The response is there. Look at again. You have incomplete blinking, you have scleral show, and you have a major tear instability. Look at the tear film. It never spread over the cornea and the conjunctiva. It's a major instability that is probably from mucinic origin. So pain with no stain is in fact associated with clinical aspect that may explain this kind of symptom and what we could call a dry. And in fact, we did some exploration with in vivo confocal microscopy, and we found a major, huge density in inflammatory cells all over the region of the conjunctiva, the inferior conjunctiva, and the limbus. So this patient with no fluorescein staining had in fact different clinical aspects associated to tear instability and inflammation that was a major cause of this tear instability. So even if we don't observe relevant damage to the ocular surface, in fact, it may exist, and treating this inflammation improves the patient. It doesn't mean that neuropathic pain doesn't exist, but the first message is that before concluding that it's occurring in the brain with a brain-associated pain, it is important to understand that sometimes we don't see or we don't observe properly the cause of the problem. Here are the huge number of causes of dry. It's very difficult to sort this kind of cause because we can observe aqueous deficient syndrome, Sjogren, autoimmune or non-autoimmune, evaporative dry. Sometimes we know that in fact it's not like two different kinds of dry, and sometimes there are many overlap between the different causes. So very difficult. And in fact, when you observe your different types of dry, there is a major discrepancy between the patient. And you have here 4 examples of dry, and you can imagine which patient will be suffering the more. Probably the one with the cornea that is totally damaged. You have a bleb associated to glaucoma surgery. You have SLK, supralimbic keratitis, and you have just a post-LASIK tear film instability. You could imagine that the one in blue with the cornea that is damaged is suffering more. It's the opposite. It's a neurotrophic keratopathy on the left, and all the 3 other were suffering a lot. This led me to understand the dry disease not by a linear way, which I mean mild condition worsening to a moderate condition and to more severe condition, but something more circular. Circular means that it's a vicious cycle between a series of biological events coexist and are stimulating themselves. An abnormal tear film causes mechanical stress, biological stress, neurogenic inflammation, and inflammation causes goblet cell loss and mucinic instability. We can define exactly the same with MGD, and this is a double vicious cycle. I have no time to develop that in more detail, but understand that the cause, the linear cause, the list of causes are in fact ways to enter the vicious cycle, either because a disease like Sjogren is causing major dry condition, or by the accumulation or acute or chronic stress that may accumulate as risk factors. This is, in my opinion, important to understand why those patients are entering the cycle sometimes very quickly, and in fact have major difficulty to get out of the cycle. It's time to better understand the role of the nerves. Of course, if there are damaged, neurotrophic keratopathy may occur, but the nerves are involved in inflammation and pain. There are many, not so many nerves in the cornea, but in fact, many plexi that develop beneath the corneal epithelium and develop to make a plexus all over the epithelium with many nerve endings. and many types of receptors. Some in red are associated to pain. They are polymodal or mechanical. When they are stimulated by a chemical or mechanical stress, they develop in a noxious mode. Some in blue are associated to T regulation and blinking reflex, and normally they are not associated to pain. However, when they are totally and continuously stimulated, they may develop to a pain, the neuropathic pain mode. Of course, when the cornea is damaged, we understand that the patient may complain because these conditions stimulate nociceptive receptors. But the tear instability is associated to the fact that the cold receptors are totally in stimulation, because almost all the time those receptors are not covered by a normal tear film, and the tear instability, the increase of molarity and the increase in the decreased temperature, micro temperature of course, they stimulate the cold receptor. And when you have nerves that are continuously stimulated, you may understand that they will respond in an inflammatory way. You have here example of a cornea with a major involvement of the nerves irregularity, bed-like aspect, and many connection with inflammatory cells, the dendritic cells. You can observe that the nerves are closely related to the inflammatory cells. They are touching each other. And of course, when an inflammatory cell touch the nerve, it's for a stimulation, and in turn, when the nerves release inflammatory mediator, they stimulate inflammatory cells and communicate with them to further increase this inflammation. What is characteristic in dry and particularly in neuropathic pain patient is the fact that there are neuroma. Neuromas are those proliferation of neurons that are not inflammatory by themselves, and they may develop in neuropathic pain and in painful patients. At some moment, it has been considered as more or less specific of neuropathic pain. In fact, no, it is not. Because in severe dry or chronic dry, with some involvement of the cornea and the nerves, we may observe those neuroma, and it's not specific, but it may be an indicator that effectively from the tear film, the disease is moving to the nerves. But at some moment, pain becomes autonomous. It may be observed with signs of symptoms of hyperalgesia. What is causing a pain is causing a more important pain rather than expectation could be proposed. And allodynia is when a touch effect or just a mechanical stimulation is causing pain instead of causing just a sensation of contact. You have exactly that with herpes zoster. But when the pain in the brain is disconnecting from the cause of the pain, so dry has improved, the cornea has improved, but there is still pain, it's due to the trigeminal pathway that is connected to the brain, exactly in the brain stem, and the pain receptor or the pain pathway is itself associated to the thalamus and other frontal nuclei that are associated to the mood and to the brain sensation, which means that at some moment there is an impregnation of the pain inside the brain. This is in animal models. In the brain stem, the stimulation of the neurons in green, there is an overstimulation of the nuclei of the neuron, and in red you have the observation of the glia, the microglia that is continuously activated. This is a biological observation, histopathological observation of pain in the brain, despite the fact that the cornea has improved. There are some attempts, and I want to acknowledge the role of Anat Galor and other experts in the field that try to discriminate dry from neuropathic pain, so neuropathic versus nociceptive pain, the fact of using anesthetics in the cornea that may decrease the pain if it is related to the cornea or not if it is related to neuropathic pain. This may be interesting, but honestly, in many conditions, there are an overlap between two, and many patients are suffering from the cornea and suffering from the brain. And of course, they are not really improved by the standard treatment. We have to take care of other factors, psychological impact, the vicious cycle of depression, very poor quality of life, chronic pain, chronic discomfort, increase the level of depression. And in depressed patients, we know that they will feel even worse when they are suffering. But there are also systemic diseases, small fiber neuropathy, fibromyalgia, which increase the feeling of pain and the receptors and the threshold of the receptor that may increase pain sensation instead of minor irritation or just non-painful or painless stimulation. And of course, toxic compound or the impact of the environment. So to finish, it's very difficult to treat those patients. The first step is really, like in my first case, to look for an objective origin of the pain. It can be MGD, instability of the tear film. Sometimes it's very difficult to observe. It is in the superior limbus, it is in the nasal conjunctiva. Sometimes it's just tear film instability, the mucin, the goblet cells, and we are very poor in observing the goblet cells. So measuring inflammation is also would be a way, and hopefully we will have more and more biomarker, and trying to tackle inflammation with different immunosuppressants or steroids. Autologous serum or plasma may be interesting to decrease pain. It improves the cornea, but it may also decrease the pain sensation, just like some scar lenses, that may also stop the mechanical abrasion or mechanical stress of the eyelid over the cornea. It's not only a mechanical, it's also a biological, because if you have inflammatory eyelid, of course, the inflammation will be continuously in contact with the cornea and stimulate the corneal nerve. So it may be also a good way to decrease pain. Botulinum toxin, especially in blepharospasm, may be useful because the spasm due to pain increase by themselves very painful. Filtering blue light, essentially blue light, that is a major cause of photophobia, and painkiller, antidepressant, gabapentin, pregabalin. But in that case, I would suggest to have a multidisciplinary approach with specialists of pain rather than as ophthalmologists using this medication to decrease pain, and sometimes alternative therapy may be used. And the last is probably empathy. And I would wish to finish with a quotation by Anat Galor. And I really think it's very useful. Those patients are suffering. And if you tell them, I cannot make any more, I cannot do any more for you, it's finished. It's really something very dangerous. I want to remind you that some patients with pain, especially after LASIK, committed suicide for this chronic, intractable pain. So never tell the patient, I have nothing to propose. Continue to listen to them, to be there with them, to propose them some approaches, some treatment, even if it's not totally satisfactory, but don't give up with them. Thank you very much for the invitation.
Thank you. Wonderful talk. I think we'll keep the questions at the end and we'll have a discussion because a lot of things are connected to this talk. Shiham, if you're ready, you can do your presentation.
Yes.
And then the next one will be Dr. Antonio. And I told Dr. Pooja to club both the presentation at the end.
Okay. Do you see my screen? Do you see my screen like this?
Yes, it's come.
Okay. Thank you, Dr. Wright, for giving me the opportunity of talking about this very interesting molecule, which is the NAGA. And first of all, I would now like to thank Professor Frederic Cambaretta, because he knows very well this molecule and he helped me a lot in building this talk. Then this NAGA, then N-acetyl aspartyl glutamic, was discovered in 1964. It was initially identified as and isolated from the mammalian brain tissue, and it's synthesized by the neurons of this mammalian. And since the 1990, it's commercialized as an eye drop for allergy as a mast cell stabilizer. And it took more than 20 years to identify the role of this molecule and the main function of this molecule. And it was three main ways of use of this molecule. The first one, it was identified as a C3 convertase complement blocker. And the NAGA is blocking the C3 convertase by both the ways, both pathways, the classical one and the alternative. And then it was identified as well as a mast cell stabilizer, which inhibits the mast cell degranulation. And nearly the same year, it was also identified as a blocker of leukotriene B4, and it inhibits the synthesis and the release of the leukotriene B4 and reducing the recruitment of neutrophils. And since 1990, unfortunately, this molecule is only used for allergy as a mast cell stabilizer with some plus, which is a C3 convertase inhibitor. When we see to the classification of the anti-allergic treatment, we see that the NAGA is classified as less powerful than the dual action agents, and it's even the less classified. It's the first, and then we have the antihistaminics, and then we have the dual actions. Then it's not the very powerful, but in the reality, NAGA is the most potent mast cell stabilizer agent. But even, and we will demonstrate that's even better than the dual action molecules. Some publications suggested that in the treatment of mild allergic and moderate and severe allergic conjunctivitis, we have that we know that this NAGA is more effective than other drugs in the same therapeutic class, which suggests this underlying superiority. And this now we have this clinical evidence that a specific complementary pharmacological action is belonging to this molecule, to the NAGA, and now we have this true role and power of the NAGA, which is the source of potency. NAGA and this now with these publications, what they compared the effects of the NAGA with dual action molecules, and as you see, at the first week of treatment, the dual agents are more potent, of course, but what was surprising is after 1 week, the effect was exactly the same. The NAGA was the same as the dual agents, and at the fourth week, it was highly superior to the dual agents. And this dual action, and when we compare these two molecules, we have that the equivalent potency of NAGA, even by the end of first week, compared to the dual agent, was more powerful. And we have also an anti-inflammatory action due to this C3 convertase. And what is now a fact that the NAGA is active on the late phase of allergic inflammation. And this study that I conducted myself 15 years ago with the comparison of two protocols in the treatment of allergy, it demonstrated that the NAGA was not only effective as an anti-allergic, as a mast cell stabilizer, but it was powerfully able to reduce the levels of eosinophils, IgE, and TNF-alpha in the tear, which was a proof of its anti-inflammatory potency. And as you see in this very nice study with the comparison of NAGA and the azelastine eye drops, we see that it's divided by 4 or 5 the inflammatory cells and eosinophils in the conjunctiva, and it divides also, it reduces the TNF alpha and MCPs in the tears. And there is another action than that one we know it's only mast cell stabilizer. And in this study conducted by Leonardi, you see that the NAGA is responsible of the decrease of the signs and the symptoms of allergy, much more than the antihistaminic group. And it was in this meta-analysis published in 2024, it was classified as the 5th most powerful treatment for VKC and for VKC and IKC after tacrolimus, cyclosporine, and steroid. Then it's really now we can classify this NAGA as anti-inflammatory drug. This powerful anti-inflammatory action was demonstrated with many studies, and it was, now we know that this inflammatory power is due to the reduce of the cellular recruitment and into the ocular surface, and to decrease and reduce the production of pro-inflammatory cytokines. And it's with the and we have another effect is to block the complement activation, the C3 and C5a. And now we know that these molecules are a powerful anaphylatoxins. Then this by blocking this C3 convertase, as you see in this 3D scheme, we have that the NAGA here in like red dots. It's blocking the both pathways, and it's reducing by 80% the C3 and C4 C3 and C4 complements, and it will inhibit by 75% the dose of the complement. And by this pathway, we will have a reduction of the chemotaxin and the recruitment of the cells into the ocular surface and into the tears. And we will have also cell action with the blockage of degranulation and activation of the cytokine production. And it will decrease the release of mediation and the tissue, all the tissue consequences that we know. Now, it's a fact that NAGA is the most powerful and more powerful than the dual effect, because we have this mast cell stabilizer and anti-complement. Then the key conclusion that it's an allergy, powerful and anti-allergic and anti-mast cell stabilizer molecule. And beyond this, now we know that the NAGA is a powerful anti-inflammatory drug. We need that to use it beyond the allergy in other pathologies, such as in the dry eye. And we know that in the dry eye inflammation, and it was the first time in this study when we proved that in this study, they proved that in the normal eyes, we have C3, we have the complement into the tears of healthy subjects. Then the complement system therefore play a role in the physiopathological defense of the ocular surface. Then in the complement activation play a role in innate regulation of in the ocular surface associated with MGD and dry eye. And then it's a way, and it's like a way to consider it this NAGA as one of the treatment of dry eye disease associated with this inflammation. And this nice study conducted by Thea with the association of trehalose, hyaluronic sodium, and NAGA was very effective in the symptoms and signs of dry eye disease and MGD. In conclusion, we know now that The NAGA is the most potent mast cell stabilizer. It's a potent anti-inflammatory drug, and this anti-inflammatory efficacy is not now proved. I'm out of time. Just I invite you to the next DEOS. It will be next year, 29, 30 January, and it will be in Tunisia. Thank you for your attention. Thank you so much.
Thank you, Shyam. I'll just break a few minutes for discussion here. I'd like to ask the panelists questions or anything you have for both the speakers, because the next two speakers are going to be on the same line. And Shyam is to move out to her clinic. So Shyam, is this drop commercially available now? Is it something which you prescribed in your clinic?
Yes, NAGA. We have NAGA in Europe and in Algeria since I think 1990. Maybe Christophe is more. But when I started ophthalmology, we had already NAGA, and I conducted this study in 2005.
Excellent, excellent.
Yeah.
Anybody, Pragya, Sushmita, Aditi, anybody?
Yeah, I just wanted to just appreciate both the speakers for fantastic talks and got to learn a lot. And I just wanted to share small insights of having spent some time with Anat Kalor at Bascom under her mentorship. It was very interesting that we looked at autonomic contributors to neuropathic pain. Like, we really know about peripheral contributors and central contributors, but it's very interesting for us to see a lot of patients, especially with autoimmune dry eye, where also there is dysautonomia prevalence. We saw that there was a lot of these patients who had disproportionately high symptoms, and like Dr. Borden had presented, that there was pain without stain, but the way these patients suffered was unimaginable, generally in a very young, financially productive age group, and they're not able to step out of the house, not able to open the curtain. So I think we need a lot of work going in this direction, and newer molecules which can tackle inflammation and other blood-based therapies and other frontiers would be really helpful. And I think thank you for elaborating that topic so well. And I think we really need to care for these patients.
Thank you very much for your comment. Effectively, we don't know so much the interaction, because in that case, it's not only a cause in the cornea that is well understood or easy to understand. In dysautonomia, I would add also probably the interaction with the gut microbiota that may also stimulate you through the vagus nerve, the brain in an inflammatory mode. There are plenty of areas we are not so much comfortable, and that probably explain a part of the problem.
I had just one question, if time permits. If you had a patient who had not so low tears, but had positive serology for rheumatoid arthritis or something, and very insistent on refractive surgery, what's your take? Do you prophylactically not advise, or because we don't know how the disease evolves? So that is one area I think we don't really understand, and we don't know how much of these nerves regenerate. Doesn't happen in all the patients. So how do you deal with those patients? Do you advise, or do you say no, even though they don't have aqueous deficiency?
I don't have a definitive answer, but the question is very important, because you have precisely a small subgroup of candidates for refractive surgery that are precisely those who had contact lens and that at some moment gave up because of their dry. If they have, by definition and from the beginning, a dry, for example, after retinoid acid use for acne or something like that, or an autoimmune disease, of course, it's very, very tricky to perform refractive surgery because of the risk of increasing dry and increasing pain, because increasing the dry, I would say, could be acceptable because the patient had already dry and putting eye drops. But if it moves from dry with eye drops to a chronic pain condition, it's even worse, because they never are rid of their pain. So it's very important to inform the patient, probably in some of them to refuse doing refractive surgery. we have observed, we are using here in our hospital more and more SMILE, and we have conducted different works showing that in SMILE there is a little bit less nerves that are transected, and that and recovery seems to be better. But we are unable to, we can never guarantee that there will be no problem. So very careful in those patients, effectively. Thank you.
So if there are any more questions be asked or anything to be added? If there's nothing, then we'll move to the next speaker, Dr. Antonio.
So thank you so much, first of all. So I'm very happy to be here with you, and thank Rohit, Pooja, and the Siam to bring him back in India for although virtually. And since I was co-fellow with Ragnia, so I'm here to answer the question actually. So dry eye and refractive surgery. So how to optimize the outcome before and after surgery. So to better understand what is an unhappy 2020 patients, what are the alternative surgical techniques, as Professor Baudouin was saying, these kind of patients and how to manage them when we need to do the surgery. So starting, we need to understand that this is a complex system of different tissue of different embryological origin that they interact, as maybe Pooja will say, by several mediators, proteins, lipids that will make the same ocular surface coordinating and working together as one single cell. So, and obviously, refractive surgery makes some insults: corneal nerve damage, inflammation, toxicity of the drug. And this will alter the equilibrium, the homeostasis of the ocular surface, leading to a persistent chronic inflammation due to this stimuli, insult, and traumas. Make our patients unsatisfied. So although they can kill a wolf in 1,000 kilometers, but still they are not happy about the surgery because of the ocular discomfort and sometimes what we call refractive surprise. These are for LASIK up to 5 years. 60% of patients, they have abnormal shimmer, alteration of breakup time, and obviously it will start from day 1 to 5 years, a little bit changing within this year. 35% of patients, they have ocular discomfort after our refractive surgery despite this cataract or laser. So this is a failure of the ocular surface as a unit, as a system. A little bit our patients can understand that discomfort after surgery, alteration in blinking, but what they cannot understand, there is impairment in functional visual acuity. So it means if they blink, they cannot see properly. So if they want to read, they want to focus more, they want to drive, take the kids to school, they have a fogging of their vision, and this cannot happen in our patient. If we get panic, so we start giving drugs without any reason to these patients, obviously 44% of them will last with ocular discomfort and alteration up to 6 months after surgery. So first, check your patient. Find the high-risk one. Check the contact lens, HSV, but mostly urban high allergy syndromes because we live in polluted areas. Obviously, patients with conjunctival hyperreactivity or allergy, patients, they have an impairment in sex hormones like menopause, polycystic ovary syndrome are a nightmare for a refractive surgeon, as well as systemic disease, not rheumatoid arthritis, maybe yes, but also diabetes, also which are very common in our practice for the nerve damage, as well dyssteroidism. Obviously, chronic inflammatory disease is an issue too, and we know very well that. Then choose the right surgical technique. Obviously, PRK is the best choice in these patients because it's the recovery very fast. Epithelial nerve, 6 months, they will be back. Even if we use mitomycin, they will not impact on the discomfort of our patients. It's very well known. LASIK has 2 different causes of damage of the nerve. First, this will reduce blinking, will reduce tear reflex, but sometimes will induce a damage to cobble cells. They will alter the stability of the tear films, and this will cause a critical discomfort, which can be very severe and sustained for a long time. The corneal nerve damage cannot be avoided, but obviously, if we pre-treat them with the immunomodulating drug, we can minimize the impact and damaging of the global cells, so we'll increase the stability of the tear film. SMILE, yes, is better. We have less damage because it's the white channel is 40-60 degrees, so shorter compared to femtolasic. Tip breakup time, corneal sensitivity, corneal morphology is much better compared to LASIK at 6 months. And obviously, we need the less drugs to be used, the less lubricating eye drops, less degradation of quality of life of our patient. And sometimes, as Professor Baudouin was saying, can be very detrimental. But, and this is very interesting, at 1 year, both femtolasic and SMILE are similar. They have the same impact on the nerves and the same risk of dry eye. So watch out about stromal surgery compared to PRK. LASIK is the best choice. Subjective symptom, tear production, corneal sensitivity is much better compared to other surgical techniques, particularly to SMILE and LASIK. Then, once you choose your technique, you find your patients, then you preserve first, then treat. You need to do very carefully diagnosis, look the patients, vital staining, and pre-treat them with a specific eye drops. So in the preoperative treatment, we suggest cationic lipophilic eye drop to increase stability, reduce corneal damage, and increase patient satisfaction together with warmer compresses. This shoe is cheap, but same time effective. If I used to suggest to my patient 1 month before any surgery I do, mostly refractive procedure. We need to restore the structure, which is destructive sometimes. So when the patient has symptoms after surgery, particularly refractive surgery, particularly LASIK, we need to rebuild the mucin layer. So we need the mucomimetic long chain hyaluronic acid in the postoperative treatment will interact with microvilli, will interact with epithelium, will induce the regrowth of epithelium and reduce the inflammation itself. Because when we restore the structure of the tear film, all the mediator that I showed you before, they will remodulate the same surface, will be turning off, controlling, regulating the ocular surface itself. We always say we are just doctor. We help the body to cure itself. So to answer to pregnant question, so what do we do if we have a severe dry eye patient, arthritis or Sjogren, and we need to do femtolasic? So Dr. Suboda group did this very controversial actual paper doing femtolasic in these patients, and when managed with frontal occlusion in the inferior frontal occlusion together with autologous serum eye drops. And this is funny because autologous serum eye drops is the same suggested treatment up to now from Pedram Amra, the neuropathic group, the research group, as a treatment for neuropathic pain. This can be very useful also in this case after LASIK, although severe dry eye. It's very controversial, the thermal pulsation therapy, because it has a short effect, but is effective in somehow in the first time, and oral supplementation. These are both controversial, different paper. We did a study that was called DREAM study, and in this study we actually had a very controversial results, but there are some evidence about that still. Managing cataract refractive surgery is critical. Use a Barrett formula to reduce any surprise, refractive surprise, as well the mean absolute error that we can have. And sometimes we need to manage these patients to improve their quality of life. Obviously, cyclosporine has been suggested as an option after any refractive treatment. But actually, the results were not very good. Patient symptoms were not very increasing, as well as inflammatory mediators and cytokines in tears. So we need to improve patients' quality of life. We wanted to make them go to school, make them nighttime living and sleeping well. So it's not about signs, symptoms, it's about life and reducing the cost at the same time. That's why it's a low one to pre-treat the patient. So treating before reduce the cost because it's shift and split the money within a program of treatment and schedule. At the same time, we can be very aggressive in case of presbyopia correcting IOL to reduce refractive surprise and discomfort. That's why we use a leafy degraft before surgery, refractive cataract surgery, and we improved the biometric results. That is critical to have any of our surgery well done properly, as well as maybe doing cyclosporine preoperatively, not postoperatively. So 30-day pre-operatively treatment with cyclosporine can impact in long-term improvement of quality of life of our patients, symptoms, signs, but also inflammatory markers. So it's a critical impact 30 days before, and stop at the moment of surgery. You will have a good impact for 3 months postoperatively in such patients. So definitively, doing surgery in a context of inflammation is a very bad, will lead to very bad outcomes, not only refractive, but also for quality of life of our patient. Mostly if we miss the preoperative management, obviously these patients, 20% of dry eye that we see are well known, but the 60%, over the 80% of patients that have disease are not well known. Second, choose the surgery, PRK, more than SMILE, LASIK. Do aggressive pre and post-operative management, but don't use casual medication, don't use preservative or the NSAID, just do the proper things at the right time. So these are my suggestions in these patients, particularly in hyperopic patients where we can have some alteration intraoperatively, and we need to use in severe condition frontal plaques when dry eye is very severe, or mucomimicking long chain hyaluronic acid in the postoperative period up to 6 months. Thank you.
Thank you, Antonio. Wonderful, wonderful.
Thank you.
Do we have questions or any comments on it? Dr. Aditi, Sushmita?
Yes, sir.
Yeah.
Excellent presentation, Dr. Antonio. So my question is, how long before the surgery you are planning the punctal plugs, and you are planning temporary or a permanent one?
So actually, we do prefer temporary one. Actually, in Europe, we have a new, I don't know in India if you can use this, is a hyaluronic that we can put in the inferior frontal plug. Is like self-resolving hyaluronic acid because we degrade it within time, and this will allow us to manage the post-operative patient. So if I know that these patients are already dry eye, most of the cases I don't know, that's why I don't say it to the patient. That's why they are very angry about me, and they come in my waiting room, and maybe you can have the same patients and tell to other patients, oh, this guy is a very bad surgeon because I was very well before, and now I'm very bad, although my surgery says he's doing well. But you know, if I know these patients are dry eye, I used to treat them for 1 month preoperatively, warm compress, mostly cationic lipidic eye drops, and if I need frontal plugs inferiorly, and if I shift in the postoperative treatment with some mucomimetic eye drops. And I really love that one CM was showing the NAGA additive to the what I call like reinforced artificial tears, not something that has immunomodulating activity to remodulate, not suppress the immune system.
Thank you so much, Dr. Antonio.
Thank you.
Dr. Sushmita, you have any questions?
Yeah, just one question, Dr. Antonio. Very nice presentation. So you said very clearly that the SMILE and the PRK are possibly better in the earlier stages post-operative period. Now, is there any way we can understand pre-operatively which would be which procedure would be better for which patient? Is there any way we can screen these patients so that we don't land up with more complications post-operatively?
So this is the hot topic question. So actually we are coming out with a paper with that. We just have a minor revision now on Graves archives, checking 1,600 patients preoperatively to better understand who are the patients at risk to having this discomfort. And the issue is to understand how to follow up also this patient. So preoperatively, we have 3 tests. They are more, I would suggest first check the blinking, as Professor Baudouin was saying, because that is coming out. 70% of our patients with discomfort had alteration of blinking we didn't know. Then breakup time and mammography. And if we want to follow up without the impact of our post-operative treatment, the usual one we do in refractive cataract, Lissamine green is the best choice. because we can follow up the inflammation from pre-op to post-op without any influence from whatever post-operative treatment we have administered and suggested in our patients.
Excellent. Dr. Shafiq, anything you want to add? You're muted. You're muted.
Okay, thank you very much, Professor Dezazu, for the excellent presentation. Actually, you've elaborated a very nice, approach to clean up or cleanse the ocular surface before the refractive surgery by using some of the immune modulator. You've mentioned cyclosporin and you've mentioned the liftigrast. First, when to use that and when to use this, and is there any endpoint when you are very comfortable to start your refractive surgery?
So first of all, it's nice to see you again, the Professor Shafiq.
Thank you.
So the question is very controversial because to publish that paper where we gave cyclosporin in a healthy population because they had we were not sure they had discomfort to prove proof of concept paper was very controversial. And actually the immunomodulation, they don't suppress the immune system but just regulate. And in these patients, actually, for 1 month, there was an impact on innate system more than because of the T cell impact. So that we need a longer time, like 2 months, than 1 month. And what we do actually in these patients, we treat them for 1 month, and we are going to do the surgery. So actually, there is not an endpoint. So there is not a clear patient that we wanted to treat. Obviously, we don't want to treat with cyclosporin. It would be too costly, first, for a country like Italy, and secondly, actually, will be like difficult to accept. For worldwide is difficult. But the idea of using a new immunomodulating like NAGA or other drug like very similar that can have an impact on innate immune system in future, or on all our patients without doing any diagnosis, would be very useful because finally each one of us has very short time, so we cannot spend a lot of time with this patient doing a lot of tests. We need to treat them and avoid to be unhappy afterwards.
This was my point to ask for the second question. Sometimes the patients, of course, in refractive surgery, they are very young, dynamic. They don't want to waste their time. So we have another alternative. You might push a high dose of corticosteroids for a few days before, then you prepare your ocular surface, then you do your refractive surgery and continue with them. Whatever you want to continue, you can put them, you can plug them, and you can continue on using the immune modulator afterwards. How did you think that this could be another way to do your
actually this is actually some things that inspire us, because it was a paper from Margherita Calonge published a few years ago on the fluorometholone preoperatively. So she just used it for putting people in a specific chamber, but I think the same insult will be right in surgery or put in a very complex dry eye condition. And they put fluorometholone for a few days before surgery, short but post therapy very aggressive to improve the ocular surface, and they better manage the trauma that they have post the dry eye chamber. So this is a good idea, and actually we didn't want to use the steroid, but this paper inspired us, and that's what's coming out from you. Yeah, totally agree.
Thank you. Thank you. We have 2 more talks. Dr. Pooja will cover both because Bangalore has early monsoons. It's raining very badly and my internets are very down. So I told her to cover it up. She's going to talk about corneal nerves and also about the biomarkers. And in case we have time at the end, we will break for more questions. Pooja, if you can summarize both.
Yes.
You are in Ahmedabad, so it's very hot. You should come. Bangalore is beautiful now.
But now I'm missing Bangalore for sure.
The only thing is there are a lot of trees, because of this, because Bangalore is filled with trees, and every time there's rains, torrential rains, we have to lose few, and they cause problems to all your internet and everything else. All yours. Start.
Thank you, sir. I would like to thank Dr. Rohit, Dr. Shiham, and also Dr. Santosh Honavar for letting me be a part of this session. And thank you, Rolika and Aditi and Pratima for making sure everything is on track. So today we're going to discuss something we often underestimate when it comes to refractive surgery, and Professor Antonio has done made my job very simple. But however, I will still talk a little bit from the nerves and the healing perspective and what the future would be. So in today's era, we do spend enormous time discussing about optics, centration, laser platforms, nomograms, and algorithms. But in reality, the final visual experience of the patient is not just determined by optics, but how the cornea heals. And this talk is just about that. So when it comes to refractive surgery today, we have three types of patients in our clinic. One is that 20/20 vision, very happy with the quality of vision. The second set of patient is 20/20, but they're not so happy with the quality of vision or no, the quality of life. They think their life is messed up after refractive surgery. And the third set of patients are just unhappy. And these are the patients we really do have a problem with: decentered ablation, haze, scar formation, post-refractive surgery ectasia, and many other patients. And we've had a wonderful talk also on pain without stain. So this covers most of it. So these are the three set of patients we do see after refractive surgery. But however, just a second. However, when it comes to one of this, we always start blaming probably the machine, the technical problems, or the patient starts blaming the surgeon or the knowledge, or whether we really have done something wrong or not. So rather than just blaming the machine or the skills, have we ever realized that the fault may be in the biology, the cornea of a patient, and maybe the patient selection is accurate, but sometimes there are some underlying biological changes we sometimes don't see, and we do operate a patient based on our topographies, our clinical examination, dry evaluation. So what are we and post-operatively, sometimes they can have sterile infiltrate. If you have done a PRK, there's always a terror of scar. Then we have dry eyes, the neuropathic pain, and ectasia. So this is always an untoward, unexpected outcome we see after refractive surgery, which we do not want to see. And probably the answer is in the roots of the biology. So to simplify the three pillars, whenever we want to understand the healing, there are always three pillars we have to understand. One is the cellular biology, one is the immunology, and one is the imaging. And these three areas together explain why the cornea heals beautifully while the another develops chronic symptoms. So this is one of my favorite slides. I would like to acknowledge my work done at Narayan Netralaya. If you see the circle videos, that this is the white reflectile bodies here. These are nothing but the dead cells and the surrounding healthy cells. You can see they are nicely healthy cells. They're kind of engulfing this dead cells. But whereas here, if you see the cells are not very healthy, you can't even make out how the organs look like, the organelles look like. And this stressed or unhealthy cells are not able to engulf the dead cells, and the dead cells just keep accumulating in the in the cornea or any part of the body, and eventually this is how the cornea starts looking. The cells are dead. There's a lot of inflammatory stress, there's a lot of desiccation stress, and the cells are not able to function nicely that how it should be. And usually we do have this biomarkers present in the cornea, which is responsible for a good healing. However, here they are just in excess amount, and not like the balance between a normal and abnormal healing is just lost here, and that's what happens. So coming to the next part of the talk is the immunology, and that is where the immune dysregulation starts. In dry eye and ocular surface, desiccating stress triggers immune activation, and antigen presenting activates T cells in regional lymph nodes. And that is what happens. And this activated T cells then release inflammatory cytokines, MMP9s, and oxidative mediators. This damages the epithelial cells further and creates a vicious cycle of chronic inflammation. So I think a lot of part has been covered by Professor Antonio. So I'm just going a little bit into biology and not much into clinical aspects. So when it comes to wound healing, we always look at two aspects. One is the regeneration of the nerves, and the second is wound healing. Now we all know how the nerves function, and corneal nerves are not just sensory structures, but they are critical regulators of epithelial health, tear film instability and wound healing. And the corneal epithelium and nerves exist in extremely close communication, and healthy nerves maintains epithelial integrity. However, the damaged nerves desensitize the entire ocular surface. And Professor Budwan has already shown beautiful images again about the nerves, but this is how the healthy nerves look like, and this is what normal corneal biomarkers would have. But if you have a lot of these dendritic cells or microneuroma, then the balance of these biomarkers is just tilted, and you have a lot more MMP9s, IL-6, IL-1 beta. And if you have a microneuroma, this patient is tend to have a lot higher IL-17A, which leads to pain without stain, where it doesn't give you answer about why the patient has complaints or why the patient is not healing appropriately. This thing. So this is the type of nerve. These are the two types of unhealthy nerves we see. And it's not just necessary that you see in a dry eye patient, but before a dry eye manifests, before you see changes on your Schirmer's, T-BUT, or even your diagnostic tests, changes have started on the corneal nerves, which we sometimes miss. And the corneal nerves, what you saw, this is how a healthy corneal nerve epithelium would look like: regular, nothing to worry, equal, uneven. But if they have a lot of dendritic cells, that means there's a lot of inflammatory process going on, and the epithelial is just going to be irregular. And this is just pre-operative and not post-operatively. And even a patient with microneuroma can sometimes have a hyperplastic or a thickened epithelium just to begin with, which may not look like this regular ones, but this is just thickened. And any value above 50 or 55 is just abnormal, and this is 63 here. And this is how the underlying health of the cornea looks like. So you don't need to have corneal nerves, but even if you have epithelial map in your practice, it tells you a lot of, it gives you a lot of information about how the internal health of the cornea is. And when you do any kind of surgical intervention on this patient, be it your LASIK or SMILE, post-operatively, there is going to be an aggravation of ocular surface inflammation. The epithelial remodeling is going to be quite erratic, and these are the patients who are going to have poor quality of vision. So a patient who has a healthy nerve or healthy epithelium, they're going to have a good quality of vision. But if the epithelial healing is erratic, they are going to have a poor quality of vision. And that's not just from the epithelium, but this is the refractive error, not of a patient's eye, but from the epithelium. MS39 gives you this. And you can see that it gives you the 0.5 diopters of cylinder is just coming from epithelium for both of these patients. And that could explain why the patient is 20/20 but not happy with the quality of vision. And this is just the PSF. Now, this is something which is very new and in development. This is the NEED software, which comes with Pentacam OCT, which is going to be launched very soon. Interestingly, nowadays, what epithelial thickness, what we get is a combination of tear film and epithelium. This is how it is. So even though we think it's epithelium, it does have some amount of tear film component also in it, and it's the addition of it. The NEED software is going to help us segregate all of this. It's going to give us tear film thickness separately. It's going to give you epithelium thickness, which is minus the tear film, and it's also going to give you Bowman's layer thickness quantification. So we all know that if the Bowman's layer is on the thinner side, even before the epithelial changes starts, it's an early sign of keratoconus or a subclinical ectasia, and an irregular Bowman's also suggests this. And this is nothing but a video of how a patient's accommodative state is. So if you have an eye where the epithelium is kind of irregular, not very healthy, and tear film status is not very good, then the patient is going to have a lot more accommodative changes compared to that of what it should be. But if the tear film is kind of on a healthy state, it's just a little bit of misplacement, then the accommodative state is going to be on the healthier side. So the tear film and epithelial healing just not it affects the quality of vision, but it also impacts the accommodative state of a patient's eye. And the group has published this in past, that if the inflammation or the inflammatory nerves are not taken care of, post-operatively, the dendritic cells are going to persist. These are dendritic cells or T cells. The nerve healing is not going to be optimal as it should be. And this patient's chronic impact, if it's not, the inflammation is not taken care of, then it has a potential that it can lead to post-LASIK ectasia. So a lot of times, if your topography is normal, but if the patient is developing ectasia, then you know that it may be an underlying inflammation to begin with. So now we know that there's a lot of this this inflammatory process going on, altered hemostasis, and that is what probably leads to unwanted outcomes. But how do we identify these factors? So I have been fortunate to be a part of the work where we've developed the BioM Pathfinder kit, where it is able to measure 8 biomarkers, both inflammatory and non-inflammatory. And it's an ELISA-based kit. So you can measure all of these 8 biomarkers. This is how the cartridge looks like. This is where you put in the tears of the patient. And then after around 90 minutes of the entire process, a back-end work, it gives you a detailed report, which looks like this. This is again an AI-based report where it gives you a measurement of each of these 8 biomarkers. What's the quantification, whether it's normal, subclinical, abnormal, or abnormal. And then also it gives you the tear film metrics here. And based on the AI algorithm and combination of 8 biomarkers, it tells you whether the patient is a healthy eye, a subclinical inflammation eye, or a dry eye, and you can choose the treatment for it. So now you know that there is a lot of inflammation. So is the answer only a lubricating drop, or we should transition through something else? Once we identify the inflammation, the next question is the treatment. And modern day dry eye therapy is no longer just about lubrication, but it is about the biological modulation as well. So Trehalose acts primarily by reducing cellular stress and promoting autophagy. Under desiccation stress, epithelial cells undergo oxidative injury and dysfunction, and Trehalose just helps to reduce the stress cells and improve the cellular level. This is the video you saw. This is just an impact on this cells with 6 hours of treatment with Trehalose, and you can see that both the cell health is coming back to normal, and the lysosomal activity, which provides nutrition to the cells, is also coming back to normal. And that's what the impact of Trehalose is. Now, cyclosporin also, we know about it, and my previous speaker has covered about it, but we know that it selectively suppresses the T cell driven inflammation. It interrupts the inflammatory cycle, sustaining dry eye disease. And as inflammation decreases, goblet cell function improves, epithelial integrity recovers, and tear film stability gradually returns. And this is again some videos from whole tomography, where you can see that if you just give a CMC drop, the impact of the recovery is not as good as what a cyclosporin would do. And this is just from the desiccation stress model. Now, always a question is about a comparison between cyclosporin and lifitegrast, whether both act on the same thing, or whether when we should give lifitegrast, when we should give cyclosporin, whether can one replace the other or not. So cyclosporin, basically, as I said, it modifies the chronic inflammation over time, whereas lifitegrast blocks inflammatory cell recruitment and may provide faster symptomatic relief. So therapy must be individualized based on the patient phenotype. So lifitegrast acts on patients with early inflammation, or where the inflammation is just starting, whereas cyclosporin works on patients who have chronic inflammation, and we cannot kind of replace one from the other. Sometimes a combination therapy helps, but not a replacement. And this is just an analogy of how it works. Cyclosporin calms the immune cell activation, reducing the inflammation and boosting natural tears. Whereas lifitegrast prevents the immune cell survival by stopping inflammatory cells at the surface itself. So this is how you can give the analogy of both cyclosporin and lifitegrast. So, but this is not it. There are multiple other drugs, like you have resveratrol, you have vitamin D, you have curcumin as well. So together, these therapies do attempt to restore ocular surface hemostasis, and we have to find the right drug for each of the patient, and probably a biomarker kit would help with that. Now, vitamin D, we all think that it's, we have ample amount of vitamin D, and, why would we talk about vitamin D in eye? But vitamin D has a very important role in ocular surface, because increasingly recognized as an important immunomodulator on the ocular surface. It reduces the MMP9 expression and improves the epithelial barrier function. It enhances the wound healing and may even influence corneal collagen cross-linking pathways. And whenever we are doing for all surgeries, we recommend doing a vitamin D level check. If not specifically, it should be done for PRK patients and patients undergoing cross-linking. And this is something which is adopted adopted and published. And this is based on WHO algorithm. And a supplementation definitely helps this patient a lot. So as my previous speaker already suggested, that we should always assess the ocular surface before surgery. If there is inflammation, pre-treat when required, then do a surgery, and post-op medication also continue with one of the immunomodulators if you have. And the biomarker kit is helpful because now the TFOS DUCE-3 classification also suggests the need of biomarker analysis, a point-of-care diagnostic kit, along with an AI approach, which the BioM Pathfinder kit gives us. And it just helps us to have a truly personalized medicine where we are shifting from one size fits all to personalized medicine for each of this patient. And the BioM Pathfinder kit is not only for dry eye, but it can also cater to keratoconus patients, patients with to predict refractive surgery outcomes, both in refractive surgery and cataract surgery. There are biomarkers which also helps for vascular occlusions and diabetic retinopathies, myopic patients, and glaucoma patients. So summarize, the future of refractive surgery is not just optics alone. It is an integration of optics, biology, immunology, imaging, and regenerative medicine. And the next era is going to focus on predictive healing, personalized medicine with one of these Pathfinder kits, and biologically optimizing the surgery outcomes. Thank you.
Excellent. Thank you, Pooja. We have 5 more minutes. Any comments from, I'll start with Dr. Bowden. Professor Bowden will start first because you summarized completely all that was discussed in the previous 2 speakers. So we'll have one comment from all the panelists and we can end in the next 5 minutes. Anything to add, Professor Bowden?
No, I had a lot of interest in biomarkers. So in the past, I have been working on that. Always difficult to develop specific biomarkers for specific question, but I'm always very enthusiastic in any kind of approach regarding the biomarkers. I just want to explain that it's very important in that area to remember the question. I have seen in the past, and certainly yourself, many attempts to develop biomarkers. I remember T osmolarity, for example, that was correlated with plenty of different options to diagnose dry. What is much more important is to determine the question that is raised. Is it inflammatory? Is it neurogenic? Is it neuropathic? And what, in case of inflammation, what kind of inflammation? Can it be allergic inflammation, toxic inflammation, environmental inflammation? So everything is very, very fascinating, and I do hope we will have biomarkers in the near future that would be available. I also remember MMP9 that was normally associated to inflammation, and in my experience, it's a little bit disappointing. So I would have a question about precisely the determination of more specific biomarker rather than a more holistic approach.
Thank you.
Yeah.
Can you repeat the question? It was not clear.
Sorry. The question about a large approach to determine a panel of biomarkers versus focusing on one specific biomarker that could try to answer maybe a specific question, and not, for example, the general question about is a dry or dry. That is interesting, but at the end, not so much if we know that it's a dry.
So I think you brought out a very important point, and I did have 2 talks which highlighted why we have chosen these biomarkers, but because of the constraint of time, I did combine them. So if you see in literature, all of us here are aware that there is like a gamut of biomarkers which are responsible for dry eye or ocular surface diseases, or when it comes to wound healing as well. But because this was the first attempt for us to build the BioM Pathfinder kit, we chose the most common ones. We all know that MMP9 is always the culprit. It's the most common culprit we have. And the next common culprits are the IL-6, IL-1 beta. IL-17 has a very large role in ocular pain. So, and then also VEGF is involved in dry patients. So looking at all of this, we did choose this 8 biomarkers for now, but in future we can have more based on the territory and the disease we are treating. And why not a single one, but why a combination is because there's always a combination of biomarkers which is responsible for a pathogenesis of a wound healing, be it normal or abnormal. And that is why, a combination of biomarker and not one. This kit caters to two purposes. We can look at a single biomarker as well and treat the patients, and we can also look at a combination and treat the patient. So that's how the thought process was behind the multiple biomarkers.
So thank you, Pooja. I think we have reached the time limit of 8:45, and it is important that we should honor this time. I thank all the speakers. Thank Rolika and all the AIOS team. Thanks Dr. Santosh Honavar for this wonderful opportunity to be part of such a wonderful set of talks today. Thank you, and see you soon. Thank you. All the best.
Thank you very much.
Bye bye.
Thank
Thank you.
And thank you, Professor Shafiq, for this, for being.
Thank you very much.
Thank you. Thank you.
Before signing out, I just have one request. Can everyone just switch on their videos? I want to take a good group photograph. Okay. Thank you, everyone.
Thank you.
Thank
Thank
you.
you. Thank you.
Thank you.
Thank you.
Bye-bye.
Bye-bye. Bye.